Okay, so that's our first day for today. We're gonna start with psychiatry. Let's see. Do you think it's important for your exam to study psychiatry nicely or no?
Yes.
Yes, I think yes.
Yes, it's
Why do you
very
think
important.
Yes, it is very important.
For exam point of view, it's very high yield and they have a lot of content.
Not only this, there is something important too everyone is missing about. What it is? What do you think, guys?
Ethics.
We're speaking about psychiatry.
Oh, the side effects of medications.
No, I'm speaking why it's important in general for your exam. It's not only because it's high yield, because it's just the side effects. What else? What do you think, guys? Why psychiatry is important for the exam?
Because
So,
now
ma-
people suffer from mental health
we
a
have
lot.
a lot of
So-
Not the, okay.
in Canada.
Yes,
I
say.
think I want to say that many patients have psychiatric issues and they are seeking.
That's in general, doctor.
They are-
But if
yeah.
we are speaking about your MCCQE1, it's important for you to know why this subject is important for you to study. What do you think?
I think
we
because
have
of safety.
25% questions from this chapter or this module.
It's not only 25%, it's 20.
20.
So
Okay.
it's gonna be for you from only this chapter 40 questions.
I got
Oh.
only
40.
what was in my last previous exam.
I think you have a problem with your connection, doctor. Except if it's my connection is bad. Can you hear
No,
me,
no.
guys?
No, your voice is good. Her voice is
Yes.
cutting. Yeah.
Yeah. Okay. So the first thing you need to know, it's 40 questions.
Okay.
You did go through the topics with the checklist one time. If you didn't finish the checklist, I'm waiting for you to send it. Otherwise, you're gonna receive the first minus in front of your name. People who's just joining the WhatsApp group with AA, BB, or emoji in their names, please add your first and last name so I can add your names to the list. People who's joining the Zoom link now with iPhone, iPad, or they are using maybe a Zoom user, please change your Zoom username and use your real name. Because from tomorrow, we're going to close the meeting. Everyone is going to be admitted because we're going to just take the attendance. This plan is built with a special way. You are group number 7. It's built not to make a financial gain. It's built to see if you are working hard, if you are studying, if you are finishing all the tasks which is needed from you, you move for the next part. If you are sleeping, trying to find excuses, you are not getting any tasks done, then you're going to be just added to the next group, or you can just join the community group. They don't have frequent sessions. You can just spend time there. If you are joining this group, you are 100% voluntary to join, but 100% you are committed to study. And they think that all here is adults. Your goal is to finish this exam. You need to do exactly what other than to finish this exam with us. Yes, the pass group, the passing scores, it's 90% of people they did pass. So by the previous 6th group and 7th group, we are looking just to increase the scores. We are not looking to increase the percentage. IMG percentage, it's 50% only passing the exam. Yes, so now we are looking to improve the scores to make it high. How are we going to do this? Follow the steps which we are doing. If we say before the session, do the checklist, it does not mean for you go and do questions. Finish the checklist, do whatever you wish, I don't care. If we say after the session, you need to do this task, I don't care. Please do it. Finish the task, then do whatever you wish. Please keep the mics closed, guys. Guys.
Sorry, doctor. I don't know if there is someone open the mic.
Yeah, please close the mics, guys. So it's distracting everyone. Okay, let's start. So it's 40 questions in your exam, 3 subjects. If you don't pass them, you fail your exam. Ethics, psychiatry, and emergency. If you don't do good in them, you are done with the exam. Bye-bye. I see you next time. So please think about it. You have a chance as everyone else to proceed. It's only need from you to work hard. I have people, they are working with a newborn. They just have a new job and they have kids and they are getting the checklist done. I have people, they are getting the checklist during the break time at work. Yes, 5 minutes each topic, they move faster, they go, they get the task done. Even if they have done just half of it and the other half, I'm waiting for it still, but they are just doing their best. You can do the same too. So please concentrate now. Let's start. So we're going to go through the important parts or the important points in psychiatry. We are not going to waste our time just reading every single word. We are going to go through a very important points which you need to know, differentiate between it till you go for your exam. So the first question for today, who's going to take it?
Good evening, Dr. Abdullah.
Hello, Dr. Nahla. Welcome back.
Thank you.
Okay, so the first question for today is, what is the difference between depersonalization, derealization, hallucination, illusion, and delusion?
Can I answer them?
Yes, doctor, please.
Yeah, so first one is depersonalization, right?
Mm-hmm.
So depersonalization mean like the person lose who they are
Mm-hmm.
and they don't know who they are and what they are.
Mm-hmm.
And derealization is when they are disconnected with everything which is in the surrounding, and they just think like they are just if like some war is going on around, they are just sitting in their home and they said nothing is happening outside. So that
Okay,
is
just give me an
derealization.
example for depersonalization and another one for derealization.
Depersonalization could be like, for example, it's not my body. Like it's not my body. It's not me who killed that person. It was someone else who did that. But in fact, they did it, right?
Mm-hmm.
So that's depersonalization. And am I right?
Okay, I just
Yeah.
yeah, keep going. I'm gonna
Okay.
just go through it after that. But
Okay.
yeah.
And what's the other one?
Realization.
Derealization was like they're disconnected from the reality of the world. So I gave you example where the war is going on. They're saying like nothing is happening around, right?
Mm-hmm. Okay.
And
Okay, take the next scenario from me.
okay.
You have a patient who's just coming to your door. He's telling you, I feel like I'm floating above my body, watching myself talking to you.
Depersonalization. Here the person is like
Do you
he's
think
just outside his body.
yeah, do you think it's depersonalization or it's a derealization?
I think it's depersonalization because they're feeling they're out of their body, right? So they
So
are not connected to
yes.
their physical body, right?
So it's change in the self-awareness. Yes.
Okay.
So the person feels, or the problem here, it's about the person himself feeling something wrong is going on. Yes. So such as maybe he's getting out of his body and just seeing both of you speaking. Take the next scenario, doctor.
Yeah.
The patient's coming to you to tell you, my hands don't feel like they are belong to me.
That's again, I think, depersonalization, right?
Do you think, guys, please, do you agree with Dr.
Yes,
Huiz?
definitely.
Yes, I agree with
Yes,
you.
the personalization because it's still connected to their body.
So
Okay, so the
once,
task,
yes, once they find out that you know the answer, Dr. Huiz, they're
Hmm?
gonna change for you the question again.
Okay.
The patient is coming to you telling you, it's like I'm a robot going through the motion. I know I'm laughing, but I don't feel happy.
Oh, depersonalization again,
Hmm.
right?
So, depersonalization, yes. So it's a problem which is related to the patient himself, his own body, thoughts,
Mhm.
maybe emotions, yes. So maybe they are just telling that they are observing themselves just from outside, yes. So it can be any of these. They can combine for you depersonalization with any of the next disorders.
Okay.
So while I'm going to my work, I felt so scared. I got stuck in front of the elevator, afraid to get inside it. So I started to have a sweat,
Uh-huh.
and I think that I felt the elevator is gonna take me and fall down.
Is it a combination of decentralization with panic or anxiety?
Anxiety.
So it could be panic attack, it could be an anxiety. But the example which we said,
Yeah.
do you,
Close.
do you think
Realization.
it's depersonalization or derealization?
I think it's
Realization.
derealization because the
Realization.
Now
elevator will
it's
not.
not related to the patient himself just feeling
Yes.
his body or emotions, or he's looking at himself, yes. Now
Mm-hmm.
you are thinking about the environment maybe or something around him.
Yeah.
Right.
The next point. The same patient, Dr. Weiss, is just coming to you.
Yeah.
He's telling you,
Mm.
during the panic attack, I felt like I wasn't real, like I was just in a dream.
Mm-hmm.
What do you think it is? Depersonalization or derealization?
I think derealization maybe no, it's
Hmm.
confusing, but my
Ah.
guess is derealization.
What? No, just ask yourself. Just ask
Yeah.
yourself the question which you need to ask. What is the question you're going to ask yourself?
So I'm in dream, I'm not in
Is
reality, right?
this related to the patient himself and his body and feelings and emotions, or it's related to the surroundings?
To himself. Okay,
Himself.
depersonalization. Depersonalization. Yeah.
Depersonalization, you're speaking about the person himself.
Right, right.
Yes? The next
Yeah.
one.
Mm-hmm.
I look in the mirror
Right.
and I cannot recognize the person staring back at me.
100% depersonalization.
Depersonalization.
Yeah.
After the accidents, everything felt foggy. Like I was separated from my own life.
Depersonalization.
Depersonalization, and we're going to speak about the PTSD.
Oh, yes, PTSD. Okay.
Yes?
And
Mm-hmm.
That,
Dr. Abdullah, when around me, it's like a foggy. This personalization.
so derealization, just to tell you about it, it's like the patient is coming to you. I opened my window today in the morning and I found out that there is no sun, but there is a burger.
Yes.
Yeah, good. So I think I realize now that if we talk about surroundings, so it is a realization.
It's surrounding or environment.
I mean, environment.
Yes, so it could be the world or it could be the environment, whatever
yeah.
it is. Yes, yes. But if you're
And
speaking about yourself, it's
yes,
depersonalization.
yeah. Thank you for clarification. Very
Yes, yes. Why we're speaking about the difference between them? Because we spoke about an anxiety panic attack, we spoke
Yeah.
about depression, we spoke about PTSD. The last one,
Mm.
the patient is coming to you and he's telling you, when I smoke weeds, it felt
Yeah.
like my mind left my body.
Depersonalization.
Depersonalization as well.
Depersonalization. Yes?
Yeah. Depersonalization with substance abuse.
So
Substance disorder.
substance use. Yes, we're gonna speak about them very nicely. They are very important for your exam. Please concentrate now. If you are joining this session, you are committed to study, your notes need to be under your hands. So while we are moving, you are taking notes. Because after the session, I'm going to check about each single one of you. Whoever joined the session today, I'm going to go through the list. You sent the note after the session, you are getting plus. You are not sending it, it's another minus if you didn't send the checklist. Please take notes. Sticky notes, iPad, whatever you are just doing. If it's piece of paper, whatever it is. People, they like to type, please type. Yes? Without notes, you will never remember anything. So while we are moving, you need to know how you're going to get, so you are writing the notes. Okay, I'm going to tell you about this later, otherwise you're going to get confused. I need from you the notes. Please, everyone, your notes, I'm going to check about it. Next. Someone else, Dr. Weiss, thank you so much.
Thank you.
Someone new, please, come take the next. Come challenge. So the more
Yes, I can,
you...
Dr. Abdullah.
Yes,
I'm
yes. How are you going to differentiate between hallucinations, illusions, and delusions?
I don't know. There is something bizarre and not bizarre.
That's not the
The
difference
same.
which I'm looking for.
Not different. Okay, hallucination and what?
So you see how it is talking then, right? And left like 3 buttons.
Yeah, Dr. Abdullah, you hear me?
Okay. Yes, yes. So delusion, illusion, and hallucination.
Hallucination,
I
I
don't.
think the person will feel something was not happening. It's only imagined in his mind. For example, he will hear voice, or he will so something not present. He will feel that there is
Which one is
something.
most common, Dr. Nahla? Is it visual, olfactory, or tactile, or auditory?
Auditory, I think. Auditory hallucination.
Auditory is the most common one. Yes. So auditory is the most common one. Okay. So how are you going to differentiate between illusion, delusion, hallucination?
Can I tell Dr. Abdullah?
Yes.
Can I come
Yes.
up?
Hi, Dr. Abdullah. Assalamu
Hello,
alaikum.
hello, Dr. Asma. Yes.
Illusion is basically the misinterpretation of the real external stimulus.
Mm-hmm.
And delusion is the fixed false belief that the patient has.
Mm-hmm.
And hallucinations are the auditory, visual, and tactile, olfactory hallucinations. Yeah.
So you have depersonalization, you have derealization. And then we spoke about hallucination, illusion, and delusion. Hallucination, it could be auditory, it could be visual, or it could be olfactory, or it could be tactile. We're going to speak about all of them while we are moving. So how are we going to differentiate between them? Delusion. First of all, delusion. What is the delusion? It's a
Fixed false belief.
fixed false belief. Yes. So it's a fixed false belief. The lady, she is coming to you. She is telling you that Justin Trudeau in love with her. The lady, she is coming to you, or the man he is coming to you with, he believes that he's receiving instructions or power from God.
Is that hallucination?
No, we're speaking about the delusions.
So, okay, so a person saying that they receive instruction from God. So that is...
So if they are just telling you that they hear voices, it's different than I'm receiving instructions and they have a special power or talent which God gave it to me now. Yes? So you're going to find so many vignettes about this, about the types of the delusions. We're going to speak about it. But just think about it. It's absolute beliefs. You are speaking about the patient he 100% believes Justin Trudeau in love with her. Or the patient is coming to you. He's telling you, I believe that my neighbor, he's trying to poison me. What do you think? What it is?
This could be the delusion.
It's delusion.
Yeah, it's delusion.
So the next illusion, to differentiate between them. So delusion, it was a fixed false belief. Illusion. Illusion, the patient is waking up at night and maybe he saw his coat, which is just hanged behind the door as a person staring at him. The patient is coming to you. He's telling you, sometimes I see a chair and sometimes I find someone is just looking at me. Illusion. What do you think is the definition for illusion, guys?
Like something that is not real and the person is percepting it.
So it's like you have something in front of your eyes, but instead to see it a coat, you see it a person. Instead to see it a chair, you see the tiger. Yes? So there is stimuli just in front of your eyes, but you don't see just as it is. Yes, the patient imagines something else. Yes, so that's the illusion. Delusion, it's different. There is nothing there to imagine something else. Delusion, it's a fixed false belief. Hallucination, it's different. The patient is sitting and he's just hearing voices speaking with him. Yes? So we're going to speak about all of them. I hope that everyone got it till now. So this the next point. So we spoke about delusion, illusion, depersonalization, and derealization, hallucination too. Please concentrate because what we are doing is very important for your chapter. The first part of the chapter here, it sounds maybe a little hard because it's definitions and so on. But when you are moving forward from here, I'm not going to come back to tell you, hey, it's fixed false belief. No, I'm going to tell you it's a delusion. And you need to understand, please guys, keep the mic close. And you will need to understand that it's a delusion. Next. Who's going to tell us what is the difference between? So we spoke about hallucination here. We spoke about illusion. We spoke about depersonalization. We spoke about derealization. Yes, we just speak about all of them. Next. What is the difference between egosyntonic and egotistonic? What do you think is?
Can I answer?
Yes.
Egotistonic is when the patient recognize that they're unwell. They want the things that's happening to be gone. Thoughts, behaviors are unwanted. Egosyntonic is the patient does not accept or recognize that they like they don't want to change, or thoughts or behaviors are acceptable in their situation.
Mm-hmm.
Um,
Which one do you think the patient knows that he got a problem and which one is not?
Egodystonic, they know that they have a problem.
Mm-hmm.
Egosyntonic, no.
So, can you recall any of the disorders which is egosyntonic or dystonic?
Doctor, can you
OCD
answer?
and OCPD.
Okay, Dr. Kern. So ego dystonic and ego syntonic is very important for your exam. So what does ego dystonic? It's starting with a D. Dystonic. The patient knows or does not know. What do you think, guys?
Patient knows,
Patient
they're
knows
worried about their condition and they know
and
that
is
they
worried
need help.
about it.
So they know dystonic. They know they don't have a problem or they have a problem.
They have they know they have a
They
problem.
have a problem.
Do you agree, everyone?
Yes, Dr. Abdul.
Yes, Dr. Abdul.
So dystonic, the patient knows. Syntonic, what do you think? Does he know?
Patient does not know and he doesn't know that he has the disease or his functioning is not okay.
So, okay. So dystonic and you have S, syntonic. Ego syntonic, because we're going to come forward and I'm going to tell you it's an ego syntonic. The patient here believes that the thoughts is true or reasonable. Yes, he thinks maybe that his thoughts feels normal and it's right to himself. Yes? Guys, please. Please, it's gonna distract us. If you have noise around you, please try to open the mic, speak, and you can close it again. So, yeah. So, dystonic, the thought does not feel like me. Or the patient's gonna tell you, I'm getting upset, or it's annoying me. Ego syntonic, you need to have them in your notes. Because if you don't write them, you'll never remember them. Ego syntonic, the patient has
Thought that is true and real.
yes, thoughts is feeling normal and real to him. So, okay. Next example. Who's gonna take it to tell us is it syntonic or dystonic? Who's gonna take it?
I
Okay.
I can take it.
Okay, guys, I love participation. So I'm 100% sure that the government is tracking only me through my phone. I know everyone else thinks I'm wrong, but they just don't get it.
ego dystonic.
Egosyntonic.
This
Egosyntonic.
Thought is ego
With
syntonic.
S.
Okay, everyone, guys, write on the chat if you're just not speaking. Please write to me on the chat. Let me see what you're
Okay.
saying. Is it syntonic or dystonic?
Syntonic.
Dr. Abdullah, can you please repeat?
So it was a guy, yes, he thinks that the government is tracking him. What do you think?
Dr. Abdullah,
Yes.
can you repeat the difference between ego syntonic and ego dystonic? I didn't got it. Please.
Yes, that's what we are doing. So ego syntonic, the patient does not have a problem. The patient is okay with whatever he's doing. Syntonic. Ego dystonic. Yes? The patient is not okay with whatever he's doing. Dystonic. They're gonna just bring the patient, okay. I keep thinking my hands are dirty, even though I washed them 10 times. I know it doesn't make sense, but I cannot stop worrying. What do you think? Syntonic or
Is
dystonic?
ego dystonic?
Dystonic.
Yeah.
Dystonic.
Historic.
Yes. They don't like, remember. D don't like. They don't like what they are doing. Syntonic, they are okay. Yes? So remember DD. Dystonic, they don't like what they are doing. And usually you see this on obsessions. Egosyntonic, the example which we had about the government. What do you think? What you gonna call it? We just studied something else. What do you think? I'm sure 100% that the government tracking only me, through my phone. I know everyone else thinks I'm wrong, but they just don't get it. What are you going to call it, doctor?
It's a delusion.
Delusion. Because it's a
Yes.
fixed false belief. Can you call this as an illusion?
No.
No, there is
no
no
object.
Yeah.
There is no
Yes.
object. There is nothing just happening here. There is no stimuli, nothing. Is this an hallucination?
No.
No.
The patient does not have
Here
any
or
feelings,
No
maybe
hallucination.
crawling sensation, tactile you're speaking about. The patient is not coming for you. He's hearing voices around him. The patient does not see someone just or things which is moving around him. Yes?
Right.
So remember that obsessions is ego dystonic. It's DD. Dystonic, D, don't like. You need to have it in your notes.
Dystonic.
Yes. So now you are writing notes. Yes? You have notes under your hands.
Yeah.
Your duty is, once you find such rule here, D, D, and S syntonic, they are okay with this. You're going to get a sticky notes next time.
Okay.
You write on it the small note and you place it in front of your eyes on the wall. Do not tell me that I need to get a board. I need to go to get the, no. Simple sticky notes. You can get it from any Dollarama just around you and just in front of your eyes. If I show you now how the wall is looking like for people who is studying from the previous group, yes, which they are just finishing few things before they are done with everything, they have the whole wall just full with these papers. Why we're doing this? Because you will need something just to remind you with everything. Or if you are not doing this, I do recommend to do this. Because all the time you're going to be sitting in your place, I'm going to come back to ask someone randomly, repeat what I just said. You need to have the information in front of your eyes. Next session, I'm going to ask someone, please tell me the difference between that and this and that and this. You need to have the notes ready. Yes? So
Right.
that's how you're going to remember. So first of all, you started to read this, how you are doing it. You read this part as a newspaper. Yes? Assessment, you are coming down for assess the problem, and for formulation, you're just going to go through it. Yes, you read the first point, second point, yeah, one by one. Then you go for the management, you go one by one. Yes, next. Then after you finish the whole page, you just hold your notes. Few words on what you just did quickly. You don't need to spend time. That's how you need to get the checklist. The whole checklist, it's not supposed to take from you more than 1 hour. If you are spending more than 1 hour on the checklist, you are doing something wrong. This checklist is created to get you familiarized with the book. Now we are digesting everything important for us in the book. Then I'm going to tell you what you need to do. So please concentrate now. Work on the sticky notes. Yes. If you don't have a sticky notes, get a tape and piece of paper and just put it with the tape in front of your eyes. If you are not good with that, you don't want to just put it like this, you can use your Anki flashcards. If you are not using your Anki flashcard, you can just create a WhatsApp group or maybe a Telegram group for yourself, only yourself there, and you write on it or type on it the information which we are speaking about, because usually I'm going to come back, ask you repeat for me this. If you don't repeat it, it's a big problem. This means that you are not studying. So that's how you need to move forward from now. Please do this. Please. Next. Next. So they love to ask the next about what is the type of the delusions. You're going to find so many questions in your question bank about it. What do you think, guys?
Guess bazaar and not bazaar or something.
No. We're speaking about the delusions now. We are speaking about
Okay.
the patient thinks that others are trying to cause harm to him.
Executor.
So it's going to be a persecutor. Yes? The patient is coming to you. He's telling you, while I was going down to the street, I found them making a DG party to make fun out of me.
Paranoid.
Sorry, can you repeat that?
Someone is going down and he thinks that they are just making the DG party next to his home just to make fun out of him.
Paranoia.
Is this paranoia?
Is the reference.
Could be a reference. Why this is paranoia, Dr. Martha? Why you think it's a paranoia?
I think it's a paranoia because the patient thinks they are gonna, like, people are going to
Isn't that delusion, Dr. Abdullah?
Yeah,
Yeah,
he's
these are
having a
all
fixed false
delusions.
belief, yes?
These
So
are all
you
delusions.
need to apply it. Which one you're gonna choose here?
Like the types.
Yes.
Hello, doctor.
So, yes. Hi, doctor.
Yeah, paranoid. He had believes anyone who want to harm him or annoying him. Yeah, this is paranoid.
So, okay. So, okay. So, paranoia, it's a little different. Paranoia, we're gonna speak about it. But we need to remember the next. If you go to any of the questions bank, you're gonna find them asking about this.
Persecutory?
Persecutory, yes. You're gonna go, you find questions in it. Reference, yes. You find or you are interpreting the just regular event or celebrities which having a direct reference to you, or maybe they are just making a party, they are waiting for you down street, yes. Or the patient is coming to you telling you the song on the radio is sending a message just for me.
Reference.
Reference. Something random, something regular is happening. He's just relating it to me. The DJ party. It's just a DJ party.
Yeah.
Why they are just making fun of him? Why this is paranoia? Is he scared here?
No.
No.
So do you think it's a paranoia?
No.
No.
I don't think so.
Yeah.
So the next. The patient is coming to you, he's telling you, my neighbors are secret agents and they are working with the police. Do you want to place me in the prison?
Persecutory.
Persecuted. They are trying to harm him. The lady, she is coming to you. She's telling you Tom Cruise in love with her.
Erotomania.
Mania. Erotomania. Someone in love. Erotomania. The lady, she is coming, or the man. They love to give you the next one about man. The man, he is coming to you. I can control.
Grandiose.
I can. I didn't say anything.
Superpower.
Okay. The man is coming to you. He's telling you, I can control the weather with my thoughts.
Grandiose.
Grandiose.
Do you think it's a hallucination?
Control the.
No.
No.
Ask
No.
yourself when I ask you something like this, ask yourself, first question, you need to have it in your notes down. Is this a fixed false belief or no? Belief. He's not seeing, he's not hearing, he's not feeling.
No. It's not belief.
It's
It is
not
fixed
belief.
false belief.
It is
False.
belief.
Yeah,
It's false.
Yeah.
Yeah,
it is
it's
delusion, so it's a belief.
It's a belief. It's a belief. You're gonna say it's a hallucination if it's maybe he's feeling ants which is just crawling up on his legs, or the patient is telling you, I see different people. I see my grandmother who died 5 years ago. She's standing in front of me, 2 a.m. in the morning. What do you think is the grandmommy is asking him to do?
Hallucination.
Illusion. Hopefully, you are not gonna meet her 2 a.m. in the morning. Yeah, so that's hallucination, yes? That's hallucination. You see something, you hear something, or you are feeling something. Doctor,
Is anything
please.
wrong with this girl because of phone?
Dr.
Is anything
Miranda.
wrong?
That's the problem.
Dr. Bella, now could you please help differentiate between
Sorry, Dr. Aisha, please speak again. I cannot hear you.
could you please differentiate between grandiose delusions and schizotype of disorder?
Say again, please. You want to know the difference between delusion and schizotypal?
No, grandiose.
Grandiose and schizotypal?
Yes.
No, just guys, what I need from everyone now, do not go for anything advanced. We didn't go for it. Please take the chunk which we are doing, digest it nicely, study it nicely, understand it nicely. We're going to go through every single word in psychiatry. Psychiatry is going to be your easiest chapter in this book, inshallah. Next. The patient is telling you, while you are sitting in the clinic, the nurse is coming to your office. She's telling you, we have a patient who is waiting outside. He's just saying that he is smarter than all the doctors. What is your question here? What are you going to ask, guys?
He is delusional and grandiose. Like,
No, what are you going to ask?
Why?
Ask about the appearance.
What do you think?
Like
That he has a false belief. He has a
What
false
you gonna
belief.
ask? What you gonna ask here?
Is
Is
he
he
drunk?
No. Is he a professor?
If you are better than the doctors, why you came to me?
Why you taking
Yes. So, okay, it was just a joke, but The patient is, they love these vignettes. I don't need someone to treat me. I have a special power just to be treated.
That's
What?
grandiose.
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 The patient is telling you, my organs are rotting inside me.
Nihilistic.
Nihilistic.
They love to. Is this nihilistic?
Somatic.
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 In somatic, there is something is seriously wrong with the body.
1 second. Somatic.
Somatic. And we're going to speak about the somatic disorders.
Wrong.
Yes,
Okay.
we're going to speak about the illness and anxiety disorder and somatic disorders. So easy. So it's a delusion. The patient is coming to you. He's telling you, I feel a very bad pain. My organs is getting bad from inside. You run your labs, your investigations, everything is okay. This is different than nihilistic. Nihilistic, the next. My body already dead. Or the world just ended last week. And everyone around me, it's an illusion. What do you think? It's nihilistic.
Nihilistic.
Everything is dead or it's
Yeah.
not existing. You need to write next to it, nihilistic.
Do not exist.
Yes, the patient have a problem with the body. They don't have the organs is bad from inside, whatever it is. You think about somatic. The patient is receiving a power from God.
Religious.
Religious.
The patient is telling you, God is sending me secret instruction. I'm the only one who can hear it.
Grandiose.
Religious.
Hallucination? Is it
that not,
hallucination?
No. He didn't say for you, I hear
This is religious
or I see.
delusion.
He's telling you he's sending to me. He believes.
Yeah, religious.
That's
Different than hallucination. Hallucination, if you don't see, if you don't hear, if you don't feel, yes, if you don't smell, that's not hallucination.
Got it. Okay.
If you only believe, it's delusion. If you find a cup and you think it's not a cup, it's a mic.
That's an illusion.
That's
It's an
illusion.
Illusion, yeah.
That's an illusion. Please concentrate. It's the base for your chapter.
Doctor, then what is the difference between illusion and real hallucination?
Illusion and hallucination?
Real hallucination.
Hallucination, you don't have the chair in front of you. You imagine someone is standing in front of you. Illusion, there is something in front of you. You imagine this thing something else. You find the cup, you think it's a mic. You find the chair, you think it's someone sitting in front of you. But hallucination, you see your grandmommy, she is standing in front of you the whole night.
Right, doctor. So, doctor, more likely, like if it is a real thing, but it's object related, then it's illusion, right?
It's more if you want to say like this.
Right.
Yes?
Thank you, doctor.
So, let's see.
Yes, hallucination is like perception without the object.
Exactly.
Yes, yes. I'm not gonna spend long time here. I hope that everyone got notes on this because I'm gonna check on everyone notes. The next topic is very important for your exam. When you go for your QE1, they are trying to find out, do you know your Canadian guidelines or no? Are you up to date with it or no? So can you save a patient who's coming to you or no? Let me share my screen. Just give me 1 second. Let me share my notes. I'm gonna share my notes. It's not Toronto notes. It's just the notes, guys. So everyone goes to the go to this exam. They come back after maybe they pass it. What do you think that people they're gonna come back to tell you guys? Think about it. If someone passed this exam, what do you think they're gonna come back to tell you?
That it was easy.
It's easy, so you have to do it.
So the problem here is you stay in maybe different groups. Yes, you are waiting. You are so excited to see people they are speaking, and they come to you. Oh, you need to read between the lines. Oh, you need to study the tables. Oh, I have studied from 4 books and I did pass this exam. Oh, I did study only 1 question bank and I did pass this exam. Wrong. All of this wrong. They are coming back to tell you, you need to read between the lines.
Illusion.
But they are not telling you how you're going to read between the lines. That's why we have this group to show everyone how you're going to read between the lines. They are telling you, you need to do all the tables from TN. 1,500 pages. Every single or every 2-3 pages, there is a table. How are you going to study it? How are you going to remember it? Impossible. So that's what we're going to do in our group. Summarize it, organize it, just revise it till we remember it for the exam. Yes?
Yes.
So we will
And
do
they
our...
say, and they say psychiatry from you word. This is a big joke.
So the problem here is myself, I like your word because there is much explanation. So if you are
Right.
following everyone, what we are doing, I have people on each chapter we are doing, they are doing ACE, Canada Q Bank, and UWord. And I'm going to tell you how to do it so you can do the same too if you are wishing.
Oh, yeah.
Do not say, it's too expensive for me. I cannot afford it. It's too much for me. There is PDF, which is free. 100% free. You can use the PDF. Yes? And maybe
Yes.
after the recording, we're going to speak maybe more about the questions bank. And so, yes. So we're going to speak about the questions bank. Just remind me by the end after we finish the recording. Yes. Otherwise, do not find an excuse. If you want to study, you're going to study. If you're trying to find an excuse, you're going to spend 15 years for this exam. Please do not spend 15 years for QE1. Next, suicide. Do you think suicide is good or bad?
Bad and bad.
Are you sure, Dr. Marta?
Suicide is bad because it is haram.
Unfortunately, yes. So what do you think? What do you think, guys? Is it good or bad thing?
Bad thing.
So unfortunately, I have to tell you, it's bad thing it's happening, but it's good thing for you. Why it's good thing for you?
Because you don't have to deal
Because
with
the patient is gone, you won't need to deal with him.
One patient is down.
Yes, they bring you the patient in fall in love with Justin Trudeau. They bring you the patient, he is just looking for the DJ party. The patient is receiving power from God. The patient is having bugs inside his pants. The patient is coming to you, he's dead and the whole world is dead.
more time to the doctor.
The patient is just creating for you problems because he is motivated to challenge you for QE1. So we're going to get ready for this.
Exactly.
Yes. Who do you think is this guy, guys?
Major depression, suicide,
What do you
Yes.
think?
celebrity.
What is his name?
Robin Williams.
Robin Williams, unfortunately. So he died by a suicide in August 2014. He was 63, yes.
Yeah.
After death and autopsy, they found out that he was suffering from Lewy body disease or dementia. I'm not going to ask you now, regularly in this situation when I'm speaking about this, I'm going to just ask people, what is Lewy body? Because we have done it before. So they started to correlate what's happening here, why he died. Yes. So yeah, it's very bad. Suicide is really sad. Yes. Regardless, just what we were just joking or kidding about it, but it's really sad that someone is trying to kill himself or others. Yes. So the next question, very interesting, very challenging. Who is gonna challenge himself to improve faster for this exam?
Me.
Okay, doctor. Who's this? Is it Dr. Martha or who?
Yeah.
Okay, Dr. Martha. So,
Dr. Abdullah, can you please mute the mic of the other participants? It's constantly, there's disruption.
okay, guys, if someone is not speaking, just speak and close your mic, so it's gonna be just quiet for everyone.
You
Okay,
help.
next.
We can help co-hosts.
I'll try to assign it, but it creates a problem. Let's see if someone is just gonna keep doing it, then we're gonna just close the meeting and, I mean, not close the session, but we're gonna close the meeting and we're gonna keep people on the waiting room. So please do not watch the TV while we are having the session. Have your notes. I'm gonna check about every single one of you guys. A concerned mother asks you about health risks for her 17-year-old son. He's experienced some behavioral issues this past year. She asks you, should I be more worrying about the risks of a suicide or something else? She is telling you the guy is asking for GTA 6, and I told him, no, there is no money. If there is no money, guys, what's going to happen?
You beat up the mom.
What do you think, guys? If there is no money, is it good thing? It's bad thing?
You can borrow help.
T6 hasn't released yet.
Yeah, so it's thank you so much, Dr. West. It's not released yet, but it's future, yes. So
It's future, yes.
yes. So 6 is not released yet, guys. Anyways, please. What do you think? What you gonna answer this desperate mommy who's asking you, Dr. Martha?
So the car hasn't been released yet, or what's?
No. We're just kidding about the GTA because it's the question is not about the GTA. The question about the 17-year-old, the mother, she's telling you, should I be more worried about the risks of a suicide or something else? Do you think she needs to worry about GTA 6 or she worry about suicide or something else?
I think
that's the question.
Here they should ask, like the mother should ask, you should ask from the mother, like why she's thinking that he will do the suicide.
Yeah, I think you should call him for an assessment because, yeah, the mother might not.
Let me give you some options.
Family history.
Homicide is actually more common than suicide in the Canadian population. Suicide is more common than homicide, or I would not be concerned about either of them.
In the teenagers, the suicide is
Suicide is more
common.
than
Yes, than
homicide.
homicide. So the teenager is
Suicide
at
is
risk
more.
of suicide.
Yes, suicide is more. There is one suicide. Usually they are saying every 40 seconds.
Really?
Yeah.
In Canada?
It's not in
Oh.
Canada, just a number. They are running it all over the world, yes.
Okay.
So if it's in Canada, it's a problem, yes. So, but it's a big number. If they are saying for you 40 seconds, it's a big number. Next question. Who's gonna take the next question? No one?
I can try, Dr. Abdullah.
Okay, Dr. Nal. Let me post it for you here so you can read it. What do you think? Please read it, Dr. Nal.
A group of researchers are studying the demographic of suicide in the United States among the genders. Their study concludes that men are more likely to attempt and commit suicide. Their data lacked statistical significance and didn't reflect the reality. Which of the following is the more accurate statement regarding the nature of suicide attempt and complication? I think, the suicide, maybe common in, among the men.
Can I answer?
Yeah.
Can I jump in?
Okay, what's the answer?
I think like the suicide attempt is more done by females than men, and completion is more by men.
No, more is more completion for men.
Take it easy, guys. Take it easy, one by one.
So more attempt by females, but more completion is by male.
Yes.
Okay.
Yes.
Okay.
Yes, yes.
So let me give you some options. Men are more likely to attempt suicide. Women are more likely to commit suicide. Suicide risk do not vary by gender. Women are more likely to attempt, while men are more likely to die.
Yes.
Last option is correct.
The last option.
is
The last
correct. Yes, yes. Why do you think this the last one or the last sentence is the correct one?
Men
For suicide, there is
okay.
that person, like, because men are completed the suicide.
How?
Related
Why?
of the because there is something when the age, if they have a
not
serious
the age. It's because men they gonna use guns. They gonna use something serious.
And fall off the
Ladies,
nah.
I took 100 pills.
Medication.
I took 100 pills. I just took 100 pills.
Drama.
Yes. Her husband just coming so tired. He did work 12 hours and she's sitting at home. She's so depressed. He does not care about me. He does not look after me. He's so bad guy. The poor guy is working 12 hours. I'm gonna take the pills before he's coming. Once he get out from outside, I'm just letting you know I got 50 pills.
50 candies.
Surprise. So the poor guy is gonna have another shift in the emergency department. But if it's a guy trying to commit a suicide,
bullet.
Finish.
She did betray me. She took all my money. No money. No. Unfortunately, honey. So she did leave me and she went to the other guy. I feel so bad. I feel so depressed. Let me get my gun. Done. The guy's gun. So, the method or the biggest reason why men dies more than, please close the mics, guys, more than women is the method they are using. Yes. So they try to kill themselves, but men use more guns and more serious ways. Women often use pills. Yes. So next. Which ethnicity or demographic has a higher risk for a suicide? 14 patients. Teens. T-E-E-N. Z.
I think the white
13 to 19.
The doctor, what is the question? Please repeat the question.
which community or like
So what do you think?
Demographic.
yeah,
So
indigenous people, the
mm-hmm.
whites,
White.
the
What do you
white
think?
male, the white male teen.
White teen or elders?
Poor people, I can say easily.
Everyone is poor, doctor.
We have Hispanic, it's like that.
Yeah. So please, do you want to get options or no, guys?
Yes.
Yes.
Okay, if you need options.
Is there an option that if mom didn't buy me a GTA 6?
So yes, okay. Who's gonna take that question, the options, guys? Dr. Precious,
Yes, doctor.
please take it. So the first option for you is African Canadian, Asian Canadian, or you have a 45-year-old physician who's preparing for QE1 in the 3-month bomb plan, or native Canadians.
Native
Native Canadians.
How about the guy who's preparing for the QE1? No suicide risk for him?
Very high.
Yes, hopefully no risk. So the answer is native. Teens. We are speaking about the teens. Yes? So they have a high suicide for the teens. The age group is very important for you. So if you're thinking about natives and you're thinking about suicide, how are you going to prevent this? What do you think, Dr. Curran? How are you going to prevent this?
How am I going to prevent suicide?
Yes.
Social support.
Right. So you try first with
Anything around natives or indigenous, you need to know it as your first name. Anything about LGBTQ, QE1, you need to know it for your exam. Is it QE1 or Q1 only? So it's LGBTQE1 or Q1? No one is saying anything. This is telling us either everyone here is sleeping, yes, either they just having a sweet dreams already. So first of all, what you're gonna do here, education. So you need to educate them, increase the knowledge. Yes, please close the mic, please.
Yeah, once again.
So prevention, you need to identify and address the underlying mental illness. Please, guys, close the mic.
Please, Dr. Yes.
Yeah, 1 second. Something happened to my system. 1 second, please. Sorry.
It's okay, Dr. Yes.
Is it now?
Yeah, it's okay now. I think it's okay now. We cannot hear anything. Yes. So identifying or addressing the underlying mental illness. So if you have people, they are coming to you, maybe they are depressed, indigenous teens. After some time, you find out that they are dying. So you're gonna just be worrying about anyone is coming to you with such symptoms or signs in the future. If you are worrying about substance use and they are committing suicide because of that, you need to educate about it. So, so to be able to reduce the suicide numbers, you need to be able to identify the reason to be able to prevent it. So, yeah. So you have a teen who's coming to you. What do you think is going to increase the risk for suicide in this teen?
Bullying.
Acne.
What else?
Secondary sexual characteristics. Gender.
So it could be bullying, but I won't take bullying more. But I would
Family
take from you
support.
Family
Lack of family
issues.
support.
shameful or humiliating experience. Yes? What else?
Depression, mental health.
Maybe environmental factor.
Family history.
Family issues.
Substance abuse.
What is family
Parents-
issues? Tell me about family issues.
Parents fighting, a divorce, something.
If you have a single parent, single mommy or daddy, if you have a teen who is depressed and drinking heavily, so suicide in elderly. Do you think suicide in elderly high or low percentage?
It's high risk and
High.
they do complete it.
It's
High.
Mm-hmm.
High because they are alone.
What do you think?
High risk.
High because
High
uh,
risk.
there is a
Yes.
serious illness. There is no health
Yes.
problem.
Yes. So high risk. They have a 25 of suicides are elderly. 25% of the general number of a suicide, 25% of them is elderly. If they give you a Native American, it's not elderly, it's a young teen. If they are coming to you and telling you, if you have a patient who is thinking about suicide, do you think he's going to come to the physician?
They will probably bring them.
What do you think? They come or they don't come?
They don't come.
They don't come.
Equally, yeah.
They come.
They may come with some other complaints.
They come dead, maybe.
So
I'm
we
thinking
said that
like
25% it's elderly. 25% if you're speaking about the cause, it's alcohol related. They are saying that 80% of people who is committing the suicide, they saw the physicians in the past 6 months. They are saying that 50% saw the physician or seen the physician in the past month. So it's a high number. You have a high number.
For prescriptions?
It's not like for prescriptions, but they come to you, oh, I feel depressed. I'm so bad feeling. Oh, I feel this, I feel that. So they are heavy drinkers, so on. Yes. So you need to keep your eyes open. We're going to speak more about it till we digest it. So the patient definitely is going to come to your clinic.
I feel like the system doesn't favor that because I think doctors have to see patients for like 15 minutes. 15 minutes. So how would you like increase your index of suspicion to like
we're going to speak about the questions, about the signs, because if you have someone who's suicidal, yes, you're going to find out that he's depressed. Maybe he's having some thoughts. He's speaking with you. He's telling you, oh, I'm tired from this life. Oh, why you are drinking? Because someone is telling you, I drink every day. How many drinks? So you're asking him why you are drinking that amount. He's telling you, oh, I'm so just upset. I live alone. I have no one around me. Nothing is happening. So you're going to have some signs, Dr. Martha. It's not like someone is so joyful just coming to you to the clinic. Yes, they have the smoothie. Yes, they are coming with the cab or the hat. And they are so happy today. They are coming with the family. Yes, they are coming to see you. Yes, it's not going to be like this.
They are living alone.
Yeah. So we're going to speak about the risk factors. So, do you think is gonna be having, or who's gonna have more higher rates? Is it the upper or the middle class?
Upper.
the upper class is more
The upper class is more.
The upper class.
Usually both of them is higher than the lower class. Do you agree, guys?
No, lower class, their poverty is bad, man.
Poverty is bad, Dr. Martha, but these guys, they are busy with work. They have no time to think about suicide.
Yeah.
As much as someone who just have the millions or the billions at the bank on the bank, yes, account, they have nothing to do, yes. Cars, you bought cars. Phones, you bought phones. Houses, you bought houses. Towers, you bought it. What you gonna do else?
Take up. Do medicine.
So, so we're gonna speak about it. Someone who's working or someone who's not working, who you think that he might commit suicide more?
The one
Not
who's
working.
Unemployed. Yes, unemployed. A patient who is coming to you, he and his family coming from a war zone, wherever it is.
Yeah.
And he's coming to a country which is very poor. What do you think?
Come back.
Is it a high risk for suicide? Is it a low risk for suicide? What do you think?
I think she's not the high risk.
Of
We have
course.
two
Of
factors
course.
already.
Yeah.
Of course.
Back-to-back stressful events.
Yes, yes. So I need you to remember the next risk factors. Risk factors. Risk factors. D, A, S, and lastly B. What is D?
Depression.
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 Usually 15% or so. A.
Age.
Age more than 65.
Alcoholism.
Okay.
Oh. Okay.
S.
They change.
Social
Sex.
support lacking.
S.
Previous
Don't
suicide.
attacks of suicide. Family support.
Schizophrenia. B.
Bipolar.
Bipolar or borderline?
Borderline.
So you need to remember them. Mood disorders come first. Yes. 15% if it's a depression. If it's a bipolar, it could be higher than depression. You need to remember alcohol, substance use, 15%. Schizophrenia, 10 to 15%. So alcohol, 15, schizophrenia, it's 10%. Someone is gonna jump in as usual. Doctor, our book is saying 10 to 15. Do we remember 10 or remember 15? Please remember whatever you can hear. Yes. So they don't usually play much here, as much as they give you a list and they ask you which one is more common, which patient is more common to commit suicide? Patient who is depressed, patient who is alcoholic, or a schizophrenia patient?
Alcohol?
Depressed patient.
DASB, remember it.
Depressed.
Dr. Blue, what was for B?
B, it's
Borderline.
borderline personality disorder. It's
Borderline,
5%.
okay.
Yeah. Now they are asking Dr. Kern. In the next patient, Dr. Kern, what do you think? What is the highest history is going to suggest for you a risk or a higher risk for a suicide?
History of MDD. That's what we just discussed, right? A history of major
Dr.
depressive disorder.
Kern,
Previous
wake
history
up.
of suicide.
Thank you so much.
Yeah.
Anything is
History
gonna
of
be a
suicide.
previous history.
Yes,
If
right,
they
right.
asking about stroke, it's a previous stroke. If they ask about suicide, it's a previous suicide. If they ask you about a previous complication with the pregnancy, it's gonna be your history. Yes, except if there is something else, we're gonna speak about it.
Yes, previous history.
So, who do you think is a higher percentage, or there is a higher percent to commit suicide? Physicians or patients?
Physicians. Physicians.
90%.
Physicians have a higher risk of a suicide rate more than or higher than the general population.
Why is that?
Which specialty is the highest, Dr. Martha, do you think?
I think
Anesthesia.
Psychiatry.
Psychiatrist.
Psychiatrist.
Isn't it anesthesia?
Because
It's
they
a
know how to.
recent data. It's just suggesting, yes. So,
When I study psychiatric, I have many illness. Oh my God.
yeah, so it's psychiatry. They are doing a few studies. I was just looking into it. They're saying even the family physicians and surgeons, they still have or they are having a higher risk of a suicide as well too. So, who do you think? Female physician or male physician?
Male physician.
Male physician.
Female.
Male. I can't tolerate, I think.
Male.
If it's only genders, you know what is the answer. But if you are comparing between the female physician and the general population, female in general population and female physician, which one is higher?
Female physician.
Definitely, it's the
Male
physician.
Yes.
Yes, female. So they are saying it's 4 times higher. If they're asking you about the risk factors, you need to remember the next. Previous suicide attempt. Second, family history, male gender, family history of a child abuse, a history of a mental disorder, history of alcohol, and so on.
Previous attempt?
Previous, yeah.
Previous attempt is number one. It's number one risk for you. Family history of a suicide, number two. Male gender, three. History of a child abuse. If you have a child who was abused, what do you think he's going to do when he gets old?
He can repeat the pattern.
He's going to do the same.
Yeah, he will do the better.
He's going to do the same.
Yeah.
What is the protective factors for you? What do you think, guys?
Family support.
Family support could be. So connection with the family. Second. Pregnancy. Do you think pregnancy is a protective factor or it's a factor which is increasing the risk of a suicide?
Protective. Protective.
I think it's protective because you get some
Usually it's a protective because you have a hope, you have a new baby is coming to you, you are so just or you're waiting for this. I'm not speaking about anything like the blues or the psychosis or whatever it is, but we're speaking just in general. Do you think someone who's living alone is having higher risk for a suicide or if they have kids?
Living alone.
Living alone.
When they are having kids, it's a protective
crazy.
factor.
Yeah.
Yeah.
Do you think an atheist is going to be safe or someone maybe who is a churchman or a mosque man?
Church or mosque man.
Yes, mosque.
It's a protective factor.
Yes, protective.
Religion is a protective factor.
Yeah.
So protective factors, you need to remember 4 of them. Connection to family, pregnancy, responsibility for kids, so you right kids, and religious. Why suicide is important? Because if you let the patient die, you are in trouble in your exam. Do you think asking, so let me show you first. So suicide risk factors, if you look here, yes, they wrote for you male, they wrote for you the age, they wrote for you depression, they wrote for you the previous attempts, but previous attempts, it's not here. You need to get it on the beginning. This is wrong. Or I won't say it's wrong, but it's not totally correct. So previous attempt, alcohol. We said alcohol, how many? What's the percentage to commit suicide?
15%.
15%. We said depression, what is the percentage? 15%. And if it's bipolar, it's going to be higher. If it's bipolar, it's going to be higher.
Bipolar borderline, no?
Bipolar. So if it's a depressed patient, if you find him bipolar, it's gonna make it higher for you. Borderline, it's different. Borderline, it's not 15 because here you are speaking about bipolar higher than maybe 15. But borderline, it's just 5%. Did you get it, Dr. Kern?
Yes, doc.
Why we are saying this? If you come down here, let me show it to you. Previous. So where it is. So psychiatric disorder. Yes. Do you see here?
Yes.
Mood disorder, 15%. And it's higher with bipolar.
Wow.
Schizophrenia, 10 to 15. So substance use, and you have eating disorder. They wrote for you borderline down here. but they didn't try it for you. 5%. Next. Next. If they ask you who's going to commit suicide more, white people or black people?
White people.
White people.
If they give you black people or indigenous?
Indigenous.
Indigenous.
Indigenous. So if they give you a younger age teen, indigenous is high, native.
मुझे भी थोड़ा सा पानी देना है.
If they give you elderly or old age, native is a less risk factor. Why it's important for us to know about the age, guys? What do you think?
मुझे आपने कब दी थी टालमल याद हो?
Doctor, please close the mic. We can
टालमल
hear
मैंने कब खाई
what
थी?
you are doing. Please, doctor. Close your mic. They can understand Urdu.
Okay.
Hanji. Please. Come on, guys. Why it's important to study about age?
Younger age, they are getting like more emotion.
Why it's important that you know about the age? Why it's important? We keep saying it's a teen, it's more than 65, it's less than 65. Why it's important for you to know about
Because
this?
they are more, this is more able to suicide. It's
No,
age group.
why we study about it? Ask yourself why we need to know this information.
So when the
Because
patient
elderly
comes to
people
us,
are
we can
more
rule
lonely.
out and we
So
know that
you
there is a
need
risk
to be
factor.
attentive
Yes.
next time and you suspect suicide. That's why we study about the age. Next. Very important for your exam.
Dr. Abdullah, one more thing that the more, elderly people, they're more lonely. So that's why we have to ask about the age.
Yeah, because they are
Yeah.
just in nursing homes, or they don't have a
Yeah.
support, they don't have
Yeah, exactly.
family members. That's why
Yeah.
you just
Yeah.
advise them, okay, have someone to take care of you or
Mhm.
whatever. Yes. So
Yeah, thank you. Yeah.
so come on, guys. Come on. Patient is coming to you, he's a suicidal. What you gonna do?
Admit involuntarily.
It depends whether it is active or passive.
Tell me what you're gonna do, doctor.
In case
You ask about the plan. What's the plan you have? How you want to commit the suicide?
Proper documentation.
You document first that you are
Any
if the
access to
patient
weapons?
has
So if you
an
ask
active,
him that do you wanna commit suicide, can this aggravate him and make him commit suicide?
No.
I don't think so.
No.
No.
Dr. Abdullah, we can ask that what do you want to do after going home? Or what's your
No,
plan for
but
today?
can you ask him
Yeah.
straight about suicide? It's a depressed patient. He's feeling very bad.
No,
He's
we can ask
psychotic.
like have you had any thoughts of harming yourself or the other
So
people? We can ask this question.
people who's saying no. So my question
Yes,
here: can you
you
ask him
ask, yes.
directly about suicide or no?
How come?
Yes.
Yes, you can.
Yes, you
Yes.
can.
Like,
Yes,
So
you can.
you can.
directly, someone is asking how you're gonna ask directly. You can ask him, "Hey, dude, are you planning to kill yourself today or no?"
really? I can't believe it.
No, I'm just kidding, guys.
No,
I think no. I think
Screening
I'm
no.
just
We should not
kidding.
ask.
No, you're gonna just screen for it, yeah? So are you gonna
Yeah.
think, have you had the thought
And any
about
thoughts of
suicide?
harming yourself or the other people?
Yes. Did you think about suicide before? Yes. Did you wish to die? Did you feel that you are not wishing to live again or anymore in this life? That's how you screen for it.
Just
But Dr. Abdullah, if the patient really for suicide, he attempts suicide,
So,
he will ask
Dr. Nahla,
questions?
Dr.
He will-
Nahla, yes.
Yeah.
The problem here is
Yeah.
I need everyone in this group to get this point. Once you are stuck for your exam,
Go to the book.
you need to come back to the book. Once you sit for your exam, what is something everyone in this group you will wish to have it in your hand?
The book. Toronto.
Toronto notes. Once you are stuck for your exam, you will need to remember that you need to raise your right hand from the book. Once you remove your right hand from the book, you will be able to see the next Dr. Nahla. Asking patients about suicide will not give them the idea.
Uh-huh. I got it now.
Did you see the book? Next one. The best predictor to complete suicide is history of attempting suicide, previous history. When we said it's, what is the four things? What's the four letters we said, Dr. Riaz, for risk for the suicide? Give me the four letters.
DASB.
Okay. So first one, it was depression.
Yeah.
Yes, the depression. What they wrote for you here, the common psychiatric disorder associated with the complete suicide are?
Mood disorder.
Bracket.
Bipolar
They
disorder.
write for you depression. If the patient got bipolar, it's going to be high. It's 15%.
30% total.
Yes, 15%. So usually they are not going to ask you about the 15, but they can ask you about what's the high. The next.
Time. Yeah.
After this, what is the second letter after depression?
Alcohol.
Okay. They
Alcohol
wrote
and
it for you
substance.
here. Do you see?
Yeah.
Do you see how the information between the lines, and that's what we are doing for now. Do you see how they are just getting the information for you from your book? That's why I'm telling you, forget about every other book you are using for now. We're going to do TN nicely. You need to be nice with your book. Please write notes. After the session, you will need to send it to the group. Please. Please.
Sure, Dr. Adala, just not bipolar, yes, depression, the first one, yes. I don't know, you told.
Read for me this line, doctor.
Yes, higher in bipolar, yes, it's fine.
So
depression, yes, I.
You see.
Depression higher, yes.
Okay.
Okay.
So depression with bipolar is, I mean, depression
Usually
can
they
be
can,
mania
yes.
as well, but mania has no role.
We're gonna speak about bipolar nicely. Remember depression for now. Remember what we are doing for now. The next point is very important. The patient's coming to you, he's a suicidal. You did screen him. So yeah, you did screen him and you find out that he's a suicide. What you gonna do?
Is it high risk or low risk?
So usually, okay, so the high risk and low risk, you're gonna be looking for the risk factors and then you're gonna give a score. They usually don't play with you much like this. They're gonna give you either he's suicidal, either he's not, so you're gonna be screening him.
Yeah.
If he's suicidal, what is your duty? What you're gonna do? Let's say that you found out he's a suicidal.
Involuntary admission.
Admit again.
Involuntary
Volunteer. Right.
Age.
Okay, hospitalization, you need to start with it, or admission. Yes?
Yes.
So next question. Okay. Doctor. Okay, who's gonna take the next question?
I can try.
A patient is coming to you. He's a suicidal. You are planning to admit this patient. Will you admit him voluntary or involuntary?
Depends on his intention.
Okay. Do we have Dr. Andrew? Are you here today? Dr. Andrew, come take a question. Dr. Andrew. Dr. Andrew, are you here?
Hello, doctor.
Hello, hello. What do you think? What you gonna do? Will you admit voluntary or involuntary? What do you think,
Again,
guys?
if it is active suicide, we involuntarily admit him.
I will say I will form the patient involuntary. Form 1.
Very nice that you remember about the form.
Assessing
Nice.
the patient decision ability.
So, what
Doctor,
you gonna
what
do?
is form 1?
Voluntary or involuntary?
Involuntary. If the patient refuses admission, involuntary.
Thank you so much. You are going to admit him voluntary first. If he refuses, just to be admitted, you need to involuntary admit him. When you involuntary admit him, you are going to complete the form 1. Yes. And you are going to give the patient the form 30. They are not asking about it. I didn't see for a long time, maybe a few questions back. They have 1 or 2 questions on this point. Otherwise, just remember it here. It's written for you here. And you're going to find it by the end of the chapter as well too. So you are giving them the form 30 just to notify them about the admission. I don't want you to get crazy about it. Oh, 43, 2, 3, 1. Please remember this for now. So you have the patient, he's coming to you. You are hospitalizing him for now. Yes?
Yes.
What you're going to make sure? What is your duty as a physician now? What you're going to make sure of?
Safety. Patient safety.
We don't leave him alone.
Yeah.
Okay.
Safety.
You go to your options, you don't leave him alone.
We ensure that we remove all harmful objects from near the patient.
You go to your options, you don't find removing harm objects.
Ensure safety.
Ensure his transportation?
So it's ensure safety. It's like study suicide. But you didn't know what is inside suicide. It's like general, just suicide. But you didn't know the risk factors, what you do, what you don't do, what is the management, what is the screening questions, you didn't know anything. What do you think? What else?
Document. Document everything.
No, document it's something you're gonna do. Okay, you're giving the forms, whatever it is. What you need to make sure of here. So people, what they were answering, it was correct. Their answer is correct, but I need something more.
Make sure somebody with him. He will not leave him with
yes.
a family member. Yeah.
So do not leave them alone. Ensure their safety as well as yourself and the staff. Remove any dangerous objects which is located around you or around the patient, sorry. If you have a patient who's coming to you, he got a plan, he's telling you, I got the gun, I got everything ready, I know I'm gonna go back, shoot myself. Hospitalize, remove, safety, make sure everything is okay. Do not leave the patient alone, and so on. If the patient is telling you, I woke up today, I feel just so depressed. You ask him, do you have a gun? Do you have a plan? He's telling you, no, I don't have. Do I need to have one? What you gonna do?
This one is
Reassure the patient.
No, reassure. So once you reassure, he's gonna go outside and kill himself. What's gonna happen to you? You need to make sure that everything's okay. How?
Remind
Ask
them
for
of
family
what they
support.
live for.
Away the gun.
Maybe yes.
Safety plan.
Make a safety
He
plan.
has
They love to
written
ask
any
about it.
letters for anybody.
So, okay, safety plan. What else?
Any will written?
You need, what you gonna advise him in this situation? If he's telling you that they are just making fun of me all the day at work, will you report to police? Will you report to CAS? Will you
Psychiatry.
report to CMPA? Will you report to your psychiatrist?
Psychiatrist.
Psychiatrist.
Yeah.
No one, no one, we will not report to anyone, right?
You don't, all of them wrong.
You have to, if we have to be.
Everything I said, it's wrong.
Yeah, but
You are
we
not reporting to anyone. You are the one who's treating. You are the one who is assessing now. You are the one who's doing everything. You are the psychiatrist now. Usually, if, except in few situations, we're going to go through them. You don't refer. Once you see refer, it's the wrong answer. Except in few situations. We're going to speak about them later, which you need to refer. What is your advice here, Dr. Riaz?
To be connected to the family and friends,
What else, please?
and ask about the work environment. Why he's worried about toxic work environment, and we need to confirm that whether this is real or he has some false belief.
What else, please? What you gonna advise?
Little underline, because if you using alcohol, you have to avoid alcohol, for example.
Yeah, so if there is a reason, you need to avoid it.
Okay.
If it's work, the reason, what you gonna say for him? What you gonna tell him?
Take some time off.
Change job.
Maybe.
Occupational. Take some time off.
Okay.
No, I think he should inform his or her manager if there is a work environment issue, just to be.
Okay.
Change the job.
Coping strategies.
CBD.
Which strategy?
Like coping, suggesting a coping mechanism or coping strategies.
I think CBT, because he has some negative belief about the work environment, so it will help.
So you could suggest maybe they would love from you, maybe you could suggest change
work environment.
Yes, because you don't, or you cannot, or you don't have time just to play games with it. Oh, did you speak with your manager today? Did you? What did the manager tell you? Oh, you had to tell him this. It's not your duty here. Yes, and maybe he's gonna speak with the manager. And the manager is gonna go for the guys. Hey guys, don't do this for him again. The manager is gonna go to his office. They're gonna come back to him. Oh, your nose is bigger today. The guy is more depressed. Yes?
Yeah.
So please. The patient is coming to you with a depression and he is developing a severe symptoms. What you gonna do? Or maybe there is a psychosis.
Admit.
Treat the underlying psychosis or depression.
You need to think about hospitalization.
Psychosis, yeah.
If the patient is coming to you with alcohol, and as they know that Dr. Nahla did find out the answer, you're going to advise him to stop alcohol. The patient is telling you, I did stop alcohol, but I still think about suicide. What are you going to tell this patient?
Hospitalization.
What you're going to tell him, it's different than what you're going to do.
Stop alcohol.
Yes, yes. He came to you, you did advise him as Dr. Nahla did. Now he's coming to you, I did stop alcohol, but I still am thinking about suicide.
Maybe you can ask him how long he ceased the alcohol intake for. Because he can say he stopped, he tried to stop, and nothing happened, then he went back.
So,
society.
if it's suicide-related substance or alcohol, once you stop suicide, you're going to find the symptoms resolving within a few days.
Yeah.
But once you find your patient with alcohol and you did stop alcohol, he's coming to you after maybe 3 weeks. I am thinking about suicide. No alcohol. What are you going to think about?
Withdraw.
You suspect depression. You suspect depression. You suspect depression. Yes?
Yeah.
So we spoke about hospitalization, documentation you need to document. We spoke about the forms quickly, what you're going to do here. Yes. If the patient is not having a plan or it's a low risk patient, he is not having a history, there is no depression or whatever. Yes. You need to advise, you need to recommend maybe some of the groups. Yes. You need to maybe give him contacts for the emergency department, advice to go there or just to contact them if he's having the ideation again. So we spoke about the patient with depression. If symptoms is severe or psychotic features, you consider hospitalization. We spoke about the patient with alcohol. Yes. So it resolves with abstinence for a few days. If not, suspect
Depression.
Yes. So schizophrenia, we're going to speak about it. Next question. Someone new, come to try your luck for the next question. The more questions you take, the more you engaged in the discussions, the more information you're going to retain in your head.
Yes, Dr. Abdullah.
I can take it.
Yeah. Okay.
Yes.
Any one of you guys. The question is saying, you have a patient who is coming to you. You do think that your patient got a suicide ideation. What's the best next step for you?
Is it active or passive?
You need to check about it. Yes. Is it he has a plan? Is it a serious one? Yes. The patient got a lethal maybe weapon. He just got a plan. I'm gonna go today through this specific bridge. I'm gonna throw myself. You screen, you don't find any risk factor. The patient is low risk. But you are suspecting that he is a suicidal. You are not just excluding the suicide diagnosis. What will you do here? What do you think, guys?
Give him.
So the question is, you have the patient and you are suspecting. You did screen for the patient, you find no risk, but you're still suspicious.
Admit. Hospitalized.
Hospitalize. Your answer is H. Take him to the hospital, or hospitalize or admit him. Why? If it's a suicide, if it's a patient who you are just suspecting that he's a suicidal, you need to make sure that this guy is hospitalized. Because in any condition, if you let him go and he dies or kill himself, you're going to get in a big trouble. Did you get it all?
Yeah.
So you need to admit psychotic or psychotic disorder. So who's going to tell us what is the difference between positive symptoms and negative symptoms?
Dr. Abdullah, positive symptoms are like delusion, hallucinations,
That's not
disorganized
the
behavior.
difference which I'm looking for. That's really right what you are saying, but that's not the difference between them. What's the difference? Why? If it's just
Something like I understand positive is when the symptoms are added onto your like hallucinations, delusions, and when it is negative, the symptoms are things are taken away, like you don't take care of your health, don't
there
take
is
care of
another
your
difference. It's not the difference what I'm looking for. What do you think, guys? What is the difference I'm looking for?
Prognosis, maybe.
Not prognosis. What do you think? Dr. Curran,
Yes, Dr. Abdullah.
please tell me.
Okay, so all right,
Difference
so
between positive and negative. So I gave you the book in front of your eyes. Tell me what is the difference.
so
Is it
the
the
negative symptoms would be like ideation,
Okay. Dr. Ahmed.
Can I try?
Yes, doctor, please try.
Yeah, so I think negative is like absence of something and positive is presence of something. So,
That's not what I'm
or
looking for.
or active or it is something about that line you're thinking?
No.
We
Like
can
there is
make
a
diagnosis due to the positive symptoms. We can make a diagnosis if they are present more
The
than two positive
difference which
symptoms.
I need
You
you
mean
to
like the
know.
etiology?
No. The
With
difference.
medication, positive symptoms will go away, but negative symptoms will remain.
That's not exactly the
Do
correct.
you mean with positive symptoms is something that the patient presents with, but the negative is
So
something that
the
we
doctor,
find?
no, the doctor who's saying with medication, the positive is going to go away and the negative is going to stay, it's a big problem because this means that you are not treating this psychosis or psychotic disorders. Yes, because you're saying it's positive, it's going to be treated and the negative is going to be staying or it's going to stay for you. So it means that you're not treating. It means that you're just wasting the time. Positive symptoms, what they need you to remember and know the difference here. Which
Is
receptors
it
do you
about
think?
dopamine?
Yes, dopamine.
That's the etiology, isn't it?
The positive symptoms are associated with dopamine and
Okay,
negative with
doctor. If
serotonin.
you are saying it's etiology, you need to know the difference which they needed from you. Is it etiology? So do you consider etiology as a difference between them or no?
Yes.
It's different. It's different. It's a big different. It's the most important difference between them. That's the most important one. Why? Because if you are saying that positive is going to depend on the dopamine and negative, which receptors?
Serotonin.
Dopamine, serotonin, maybe both
No.
of them. So serotonin more, but yeah. So if you are speaking only about dopamine, which medication you're going to use?
Antipsychotics?
Yes,
Antipsychotic.
antipsychotic, but there is two types there.
Oh,
Type 1 or type 2?
Typical ones.
Type 2.
If it's only dopamine,
Typical ones are
which
the
one?
dopamine antagonists.
Yes, yeah. So you're going to use type 1 or type 2? What do you think?
Type 1 then.
Type 1.
You can use type 1 because they are working on the dopamine receptors. If you are thinking that the negative is working more with the serotonin, or they have a problem with the serotonin, are you going to use for them the type 1?
Type 2 then.
Then you're going to use type 2. Because type 1 is working only on dopamine. If the patient is having a problem with the serotonin, you cannot give them type 1. So you're going to go for type 2. Type 2, because it's working on both receptors, serotonin and the dopamine, you can use it for positive and negative. But type 1, usually use it for the positive. We're going to speak more about the medications, but this was the biggest differential which I wanted you
Sorry,
to have
Dr.
it in your
Abdullah.
notes.
It was not clear that for the positive it means dopamine, and for the
Dopamine.
negative it is serotonin.
Serotonin.
Okay, thank you so much. I appreciate it.
Yeah.
Excuse
That's
me,
why
what is type 1 and type 2?
We're going to go through the medications. We still didn't go there yet. It's just because the antipsychotics, they have two groups. Yes, they have the old groups, yes, which you are using, and they have the new one, the risperidons and so on.
Good.
We're going to speak about them. So, positive symptoms, you need to remember it. Delusion, hallucination. I think that everyone now is mastering delusions and hallucinations and illusions and so on. They wrote for you the definition on the side here. Disorganized or abnormal motor behavior. What is anhedonia, guys?
Loss of interest.
Loss of interest. So the patient does not, he's coming to you, he was enjoying to play GTA 6, now he's not enjoying it anymore. So what is the avulsion?
Lack of motivation.
Lack of motivation.
Demotivation, or the patient has a list wish. What is alogia, guys?
Lack of speech.
Difficult.
Where do we see it?
In depression.
Where we see it in this chapter, they left two areas to speak about it. Autism and dementia.
Yeah. Oh. Yeah.
Psychosis. A patient is coming to you, he is known patient for you for a schizophrenia. He's presenting to you today with psychosis. What do you think? What will you do? He's coming to the ER. Favorite board question.
We will give haloperidol and lorazepam.
So you're going to give the IM medications, very nice. But what else? If they don't give you medications, they need from you intervention, something else to do.
Safety of patient.
Safety of
Patients and staff. And yourself.
patient, staff, and
Yourself.
yourself, and who else you forget about?
The patient.
Other people in the department or other patients. Have an exit strategy. Yes. Keep this patient
Dr. Abdullah,
under.
I'm lost here.
Yes, doctor.
Sorry, I'm lost here.
We are speaking about this point, which is here. We didn't just go, we're going to digest what we are saying now. It was just something general. Let me see if it's still here.
So we have a patient who has schizophrenia but comes to us with
acute
psychosis.
psychosis and mania, yes. So if the patient is coming to the emergency department, they are looking for you or looking to you to use the Halo R. We're going to speak about the Halo R later when we go for the medication. That's your emergency treatment. It's usually you have a combination of drugs. You need to remember them for your exam. It's Halo R. We're going to go through it. But now remember that if it's coming to the ER, you usually go and give IM You're going to give haloperidol and lorazepam. If they don't ask you about what you're going to do, this is emergency, yes, but what you're going to do here with this patient, yes, what is the best next step for you? Ensure safety of yourself and the other staff. Make an exit strategy. If he get more psychotic or he's just getting more aggressive, what you're going to do in this condition? You need to make sure that, what do you think, what else you can do in this condition, guys? You did admit you made safety, you make sure of the safety, you just made your exit strategy. What else you could do?
Blood work. Suicide?
As we did in suicide, so you don't do suicide, but as we did in suicide, you remove any dangerous objects. What else, guys? What do you think that you're gonna do else?
Safe place.
Patients in a quiet place. Yeah, safe.
You need to decrease the stimulation which is happening. Patient is coming to you. He is psychotic. He is manic. He's coming to the ER. Do not keep him in the emergency department. Everyone is running. And the guy is sitting in between. He's psychotic. He's aggressive himself. And you're keeping him much light. You have a trauma coming. Ambulance is getting in. Policemen, straighten this guy. And this guy is sitting in between all of this. What do you think he's going to do? He's going to get crazy, yes? He's going to keep jumping everywhere. He might harm someone. He might attack someone. So try to get him in a quiet place. Will you use antidepressant in this patient?
No. You cannot use antidepressant alone.
You cannot use antidepressant here or stimulants. What is the stimulants we are speaking about?
Methylphenidate.
So never use it for this patient who is coming to the ER. So if you have a patient who is psychotic, usually, which labs you're going to do? Because usually when you have a psychotic patient, oh, I'm going to treat him in the ER. I'm going to give him the intramuscular antipsychotic and lorazepam. I'm just going to strain him. Oh, I'm going to just ensure safety. I'm going to make an exit plan. I'm not going to give him antidepressant. I'm going to keep him in a quiet room. But they might not ask you about this. They might ask you about which labs you're going to run here.
Urinary drug screen.
Coffee blocker with
So
differentials.
you could do your CBC, you could do your drug screen. What else you could do, guys?
Blood alcohol levels.
Electrolyte check.
You could do your
Urine drug
NFTs, you
screen.
could do your ACGs, yes?
Thyroid function test.
So they wrote it for you down here.
12.
Yes. LFTs.
Glucose.
Glucose, yes, okay.
The fasting lipids. Yeah.
Yes.
I think pro-inflammatory markers, interleukin 6 like that. Somewhere is written here.
It's yeah, I won't go much in details here because they don't usually dive deep here, but the next point is very important for you. You cannot go to your exam if you don't know what is schizophrenia. You cannot know or go for your exam if you don't know MDD and the difference between each one of them. You cannot go to your exam if you don't know your antipsychotics, antidepressants, and your mood stabilizers. You cannot. Schizophrenia. What is schizophrenia, guys?
Psychosis with delusion, hallucination.
What is the definition?
Oh, I mean, it's a disorder of, I mean.
Of what?
Reality, I mean.
So it's a thought disorder. which impairs the judgment, behavior, and the ability just to interpret the reality or the surroundings. Symptoms must be present for
6 months.
More than 6 months.
6
More than
months.
6 months.
More than 6 months.
How we're gonna remember it? You see a full page here. You are not required just to keep it. Oh, schizophrenia, A, B, C, D, E, F, G, and then you just go for your notes. You write everything, every single word. No, you were supposed to go through it as a newspaper and write few words on this topic in your notes and send it. If you didn't do this after the session, please go and do it. Do not waste your time. Yes? So,
Excuse me, sir.
yes, doctor.
Please, your definition for schizophrenia, I didn't get it well, please. I'm sorry.
It's a thought disorder. That's what you need to remember. They are not going to ask you about the definition, but just for yourself to know it.
Okay.
Thought disorder, which might impair or it impairs the judgment, behavior, and the ability to interpret the reality. Did you get it?
Yes, sir. Thank you.
Thank you. So, what you need to remember here?
Duration and what the symptoms or what the criteria.
The criteria. You need to remember 2 or more of the following. And at least 1 of the first 3. You have delusion, hallucination, and disorganized speech. You need 1 of these guys. 1. And you need 2 or more in general. For example, patient is coming to you. He is presenting to you with a catatonic behavior, and he's having avulsion and anhedonia. Do you think it's a schizophrenia? They give you 4 and 5. Is it a schizophrenia?
Depression.
It's not a schizophrenia. They didn't give you delusion. They didn't give you hallucination, disorganized speech. You need to find 1 of the first 3. Patient's coming to you with a hallucination. He is coming with a catatonic behavior. He's having a avulsion.
Yes.
Yes.
It's a schizophrenia until proven otherwise. Now, you need to have the next notes. You have it in your book, you have it in your notes, wherever you have it, I need you to have it. Delusions. They come to ask you which delusion you're going to see here, or you need to have in your head to pass this exam nicely. Which delusion is going to be here?
Auditory.
Really?
Do you have auditory delusion?
No.
Visual.
Auditory hallucination here.
Yes. If it's delusion, you don't call it auditory. You're going to call it something else.
Oh.
Yeah.
So delusions, you're going to remember it's going to be
Fixed.
delusion bizarre.
Bizarre. Yeah.
Something does not make a common sense or logic for you.
Yeah.
That does not exist.
Aliens, zombies, or my brain waves affects my food or the food. Something does not make sense. Non-bizarre, it's something makes sense for you, but you don't have it in schizophrenia. So once you find bizarre, the patient is telling you, if I go to the street, I'm gonna find a bus which is full with the aliens. They're gonna kidnap me. Yes. So Please remember it. Next. Which hallucination we're going to find here in schizophrenia, specifically schizophrenia?
Auditory.
Auditory. They're going to tell you in the question. While you are performing your examination on this patient, your patient seemed distracted. Or he's taking some time to answer you. What are you going to think about?
He's listening to someone.
Yes, he's listening maybe to hallucinations. Of course, it's not a regular patient, not every patient, but you're speaking about psychiatric patient who you know maybe, or you are evaluating him for schizophrenia, or you are trying to make the diagnosis. That's why you are suspecting this. Because I know someone is going to jump in, doctor, do we do this for every patient? Please, do not squeeze your eyebrows. The moment you squeeze your eyebrows, either you're going to get stressed or you're going to get the answer wrong. Please. Next, disorganized speech. How they gonna describe it for you in the question?
They're gonna say that when you ask him a question and he replies with something entirely different.
Flights of ideas.
No, flight of ideas, it's not disorganized speech.
Okay.
Tangential or it will not be circumferential for this one. It will
They
be
might
tangential.
look that they are mumbling themselves.
Oh, yeah. Okay. Write it down.
Flight of ideas, it's different than disorganized speech. Disorganized speech, maybe you don't understand it. It's something maybe not clear. Flight of ideas, it's different.
Okay.
We are speaking now about the casino. I was playing there. Oh, I like to swim. I like to play football. While I was playing football, I saw, when I was on the airplane, flight of ideas. Much ideas coming in. Oh. Where we see which disorder we're going to study, it has a flight of ideas.
Mania.
Borderline. Oh, bipolar.
Mania, bipolar.
Bipolar. Okay.
Manic.
We're going to speak about it nicely. You're going to love it. 4. Catatonic behavior. What is the meaning of catatonic?
Keeping the same posture, like making their body stiff in one place.
So it's slowed lack of movement. It can also be agitated catatonia, or it could be a purposeless movement. Anything they can describe it for you in the question. You need to look for the first 3. First 3 is the most important for you. So when I say for you DSM-5 criteria, you need to tell me. I need one from the first 3. What is the first 3, guys?
Delusion, hallucination, disorganized speech.
And in total, how many of the symptoms you need to find out?
5.
Doctor.
3 or more than 6 months.
WU. What does WU mean, doctor?
Wake up.
It means wake up.
2 out of 5.
It's written under your left hand.
Yeah.
At least
Next.
Okay.
For how long you need to find these symptoms?
More than 6 months.
More than 6 months.
6 months at least.
So 6 months. So do not confuse, do not go and say it's a significant portion of time during 1 month period. Maybe I'll explain it for you next time. Do not confuse you now. Otherwise, they mean for you that if you have hallucination and you're thinking about 6 months, it does not mean that you need to have hallucination just for 1 month to say it's schizophrenia. Because some people, they come, schizophrenia, they wrote for me 1 month here, I'm going to go for 1 month. No, it's wrong. If it's 1 month, what you gonna call it?
Brief psycho.
Brief.
Brief.
Brief
Less
psychotic
than.
disorder.
Yes, less than 1 month, it's gonna be a brief. If it's 1 month to 6 months, what it is?
Schizophreniform.
Schizophreniform. If it's more than 6 months.
Schizophrenia.
Schizophrenia.
Yes, so if you look to this table, less than.
Yeah.
1 to 6 months, more than, and we're gonna speak about the schizoaffective. Please concentrate on the next point because it's very important for your differentiations. Please, the next point, very important. I'm gonna look in each one of you notes about it.
Please, I have a question.
Please, doctor.
The
Before you have the question, I have a common deal. You have the question, I have the question. You answer mine, I answer yours.
Okay.
Do you agree?
Yes.
My question to you, how are you going to differentiate between schizophrenia and delusional disorder?
There's no hallucination in delusion.
There is no impairment of function in delusional disorder.
What do you think, guys?
So in delusional disorder, there is no hallucination.
Is it
There
the
is no
bizarre
impairment
thing
of
which
function.
Is it, Dr. Abdul, is it
No,
the bizarre delusion versus normal delusion? Or
No, we are
like something-
speaking about delusional disorder. It's here. It's under your left hand. Did you find it?
Schizophrenia is thought disorder. Delusion is belief disorder.
No, but you can find, so if your thing is thought and belief, okay, you can say it, but how are you going to differentiate between it? That's the problem in the vignette. The problem you could find maybe the definition. Yes, it could be correct, but how are you going to find it in the vignettes? I need you to remember the next, prepare your notes because I'm going to say it after I listen to everyone. Please say, doctor.
No marked impairment of function in delusional disorder.
Okay, functionality. If it's delusional disorder, you need to remember the patient is functioning. He's able to go to work. So this patient is functioning. Schizophrenia, do you think he's functioning or no?
No, not functioning.
He's not functioning. They have a problem. What else? What is another differential?
In schizophrenia, it is bizarre delusion, but in delusion, it isn't bizarre.
So yes. So in delusional disorder, you're gonna find non-bizarre. In schizophrenia, which delusion we're gonna have, guys?
Bizarre.
That is the second thing for you. The last one, what it is?
Duration of 6 months in schizo and 1 month in...
But you can say no, it's written more than 1 month. It can be 6 months too, yes. That's why we are trying to differentiate with other things and other information as well too. Last thing, you're gonna have it in your notes for your differentials to find them easily in the questions.
In delusion, in the disorder, there is no symptoms of schizophrenia.
Schizophrenia, you know the criteria for it. So if you are stuck here, you're gonna just apply the criteria. You know your delusions, you know your hallucinations, you know everything, so you can do it. But I need more differentials, just differentials to have it in the notes. It's not about the treatment.
Is related to the delusions.
It's about the hallucinations.
The
hallucinations in schizophrenia, what it is?
Auditory.
It's related to the delusion.
So in delusion disorder,
it can be
it's
anytime.
related to the delusion theme. So if the lady, she's having a fixed false belief that the neighbors is trying to poison her, She might be hallucinating that she sees the neighbors going around her house. Or she might be hallucinating that she did hear someone speaking that they're gonna just poison her today. It's related to the delusion. In schizophrenia, any auditory. Yes, they didn't say it's related to the delusions, which is bizarre in the schizophrenia. So the type of the delusion is differentiating it between differentiating your schizophrenia and your delusion disorder. Yes, and not only this, but as well the hallucination and the functionality.
The doctor, in delusional disorder, there are non-bizarre delusions,
Non-bizarre.
and then the hallucinations will be visual as well as
Related to it.
auditory.
So they didn't specify it for you, but it's going to be related to the delusion. So if the patient's having a problem, maybe, or he thinks about he's having whatever is the delusion he's having, you're going to find the hallucination is related to this topic. We're going to have examples for that. Yeah, do not worry. We're going to have an examples for it. So the next steps you need to have in your notes. Please have it in your notes. So you had the differentiations now. Next step for you is going to be, if you have a question about schizophrenia, how you going to approach it? How you going to attack this question to answer it correct? If you are just confused, is it a schizophrenia or no? You can apply your criteria, which you know it nicely. 2 or more symptoms, they need to be for more than 6 months. You need to find one of the first 3. Yes, but I need you to do the next. Once you find a question about schizophrenia, I need you to, number 1, you need to have it in your notes. Count how many psychotic symptoms you have in your way. While you are going through your question, you are just finding out schizophrenia question. Okay, let me count how many symptoms I have here. Okay, I found delusion, I found hallucination. Is it the hallucination which I'm looking for? Is it the delusion which I'm looking for? And you count how many you found. The next very important point, number 2. Number 2 here, you're going to look for the duration. You did look for the symptoms and how many is there. You're going to look for the duration, number 2. Number 3, you're going to look and check if there is mood symptoms. If you find mood symptoms, what you're going to think about? Your favorite. Schizoaffective. Schizoaffective. There is no mood symptoms in schizophrenia. If you find mood symptoms, it's more schizoaffective. It's not schizophrenia. Schizophrenia, you have the criteria. If you find the criteria, it's your schizophrenia. If you don't find the criteria, it's not. Did you get it, guys?
Yes.
So before we make the diagnosis for schizophrenia, you have a patient who is coming to you. You did find out the symptoms. You did find out the duration. There is no mood symptoms. What you need to rule out before giving him the diagnosis?
What duration?
What do you think? No, Dr. Nahla.
Medical condition. Other medical condition.
What you need to rule out.
Substance use. Substance use.
What you need to rule out.
Is this substance use disorder?
You're gonna find the question in your questions bank. You need to rule out
alcohol,
seizures.
Seizure.
Why you need to rule out seizure?
Focus on medication.
Mm-hmm.
Dr. Abdullah, what was your question?
What we need to rule out before giving the diagnosis of schizophrenia?
That may point at
Maybe
a
the
brain
absent seizures
lesion.
is similar to
Other
the
brain
catatonic
Medical
behavior.
conditions.
Some medication
lesion may
includes
point
the
at
threshold of
another
the
brain
fever.
lesion.
Or
What do
any
you think is?
medical condition?
So,
No.
okay. So, we need to rule out any medical or brain cause like seizures before you are saying that this patient is having any psychiatric illness, not only schizophrenia.
But what's the relation between a seizure per se or the side effect of medication? I cannot understand.
No, it's before you give anyone a psychiatric presentation, you need to rule out these things. Brain causes
We
or
have
medical
tumor.
causes. Did you get it, Dr. Nahla?
Yeah.
So before you give a schizophrenia diagnosis, you need to rule out. Does this patient is presenting to you with a medication maybe which caused for him this? Or maybe he's coming with a brain cause, maybe something like seizures or whatever it is. They are saying for you that females, they are getting it by late 20s. The men, they are having it by the mid 20s. They are writing to you the second peak in the midlife. It's usually happen in women. Do you think schizophrenia genetic or no?
Yes.
Yes.
It says can be.
Yes,
It could be
can
genetic.
Can be genetic, yeah.
Yes, yes. So, yeah, they're saying that if you come down here, they're saying decrease the frontal lobe functioning. They have, where it is, while decrease the dopamine in the prefrontal cortex. Some questions you're gonna find minors on these. They are writing for you environmental. Cannabis. Anything has cannabis on it, you need to remember it for your exam. Geographical variance, or maybe if you have, what do you mean here with the geographical variance? What do you think?
Hot climate.
Altitudes.
What do you think is?
It's more in winter season.
I wish, Dr. Sadia.
I see.
What do you think? Come on, guys, wake up. It's impossible that only two people they are answering.
Grants to changing the geographic areas.
Mm-hmm. So it's just simply, guys, maybe it's common in one country, but it's not common on the other one. Yes? So they are
Got it.
writing, yeah, so they are writing for you a winter season.
It's clear.
They are writing for you and they have a question on low socioeconomic. It's coming to, of course, it's not 100% clear or the mechanism is not understandable yet, yes, but you need to remember it. What type or kind of stare this patient with schizophrenia gonna have?
Type of what?
Stare. Staring.
Staring?
Hmm. What do you think? What do you think, Dr. Sadi?
Stereotypical.
What do we call it?
Class aspect.
Strange? No.
Upset,
Hmm. Strange, what you gonna call it?
bizarre,
Why you're saying bizarre? We're speaking about the staring. It's the same as when we were speaking that he's gonna be hallucinating, he's gonna be looking around. Which staring?
Staring means he's listening to somebody.
It's not like he's
LOT.
listening, but which type? What type? What you gonna call it? What is the name of it? What they call it usually in clinical practice?
Oh,
They call it the 1,000-yard stare or the 2,000 yard. So usually they are using one of these phrases. Yes.
okay.
So when you have someone who is coming to you with unfocused gaze, maybe, yes. So the patient look distracted, who's looking on in the corner, yes. So they can tell you this. Of course, they are not going to ask you about the 1,000 yard, but they can tell you, oh, the patient is sitting and he's looking to the corner. You are asking the patient a question. He's taking some time. Let me listen to them. They are telling me the answer for your questions. You would wish to have the same in your QE1. Yes, you're sitting in your exam and someone is telling you, oh, it's A, B, C, A, B, C, A, B, C. Done. Gone. So that's important to understand. Treatment. I'm not going to speak much about the treatment now. I'll leave for you all the treatment till we go through the medications, guys. Yes? Just remember, what is the emergency treatment for schizophrenia, guys? We spoke about it.
Haldol and
Haloperidol and lorazepam. And how you going to give it? Which route?
Intermittent.
I
IM. If it's a resistant schizophrenia, they'll love to ask about it. Let me give it to you. What you going to give?
Clozapine.
Clozapine.
Yes.
Do you see it? It's in your book.
Nice.
This information at least mentioned from 2 to 3 times in your book. If they have the same information mentioned for you 2 to 3 times in your book, what you gonna do, guys? Is it important for you or it's not important?
Memorize.
Unfortunately, you need to memorize it nicely. Next question. Okay. Next question. Okay, Dr. Sadia, come take the next question.
Okay.
You have a patient who's coming to you with a schizophrenia.
Right.
So his mother, she is worrying about the baby. She's telling you, I worry about him that he's gonna keep or he's gonna be always bad with this bad disease or disorder, in other words. What you gonna tell this mommy? What you gonna tell her that is gonna make her maybe feel good? What you gonna just explain for her that she can expect good outcomes?
Compliance to medication.
Okay.
And I will explain that
Compliance of the medication, I won't take it from you. I will take from you something else.
psychotherapy as well. CBT will do along with medication.
I would take from you good response for the medication.
Oh, okay.
This is gonna tell you that this guy is gonna have a bright future.
Okay, okay. So there are few points, like if it is acute onset, I can see the good prognostic factors. Yeah, later.
Good prognostic factors. I keep asking people about it till they go to the exam.
Right.
Please, next time, Dr. Sadi, I'm gonna ask you about it to repeat it all. I'm gonna ask you to repeat for me all schizophrenia.
Okay.
Good prognostic factors. It's telling you that this patient is gonna have a good outcome. Good support, good response for the medication, no family history, acute onset, yes. Later, it's not happening in the early 20s. Female, gender. What is the prodrome? Dr. Sadi.
Prodrome, the prior circumstances or the symptoms, prior disease.
Prodrome. Where we find it, where it's mentioned in your book.
Was prior to this active symptoms or something like that? I forget.
Where it's fine. People, they like to just link this one with something you have it in your book. What it is? What do you think they are just linking this to?
Prodrome, migraine symptoms like aura before migraine.
Migraine, or they love to speak about it in
seizures.
Seizures. Which seizures?
Epileptic seizure.
What type of seizures do you know, Dr. Sadi?
They are focal, generalized, and there are different types of seizures.
Absence.
So,
tonic-clonic.
yes. What is the difference between prodrome and the post-ictal phase?
Prodrome is prior to the incident, and post-ictal is after the symptoms happen.
So, what is another differentiation between them? Post-ictal phase, it's specific symptoms. You have a bad taste, you have a coin taste, you have a smell maybe, which is gonna tell you, or it's happening after, the opposite. Prodrome. The prodrome, it's not specific. It's early. It can happen 2 days. Yes? What is the difference between prodrome and aura?
Or immediately before the...
Immediately. So 1-2 minutes, you have the taste, the bad taste in your mouth. You have this bad feeling. You have this smell you are smelling. Whatever you have, then you know that you're going to have a seizure. This is the aura. In prodrome, what it is?
Before 24, 48 hours.
So in prodrome, it can happen 1 day before. It's something non-specific. Each one in this session, they have a prodrome. They are sitting on the other end, feeling tired. Please, guys, write me. How many of you is feeling tired now? Write on the chat, please. Let me see.
Not tired. Such a good session.
So yes, the people, they are getting tired. They are starting.
You know, Dr.
Yes.
Abdullah,
This is
always
kind of
for
3
complete
hours
the
movie.
task, for complete the task, we couldn't sleep well, wallahi. We always we have to
So
finish.
everyone in this session, they are just tired. They are not feeling that they are themselves today. Maybe they are just having a food cravings. Maybe they are so upset today, or they got crazy or mad on the kids or the husband or the wife.
In Ontario,
Maybe
it's
study
11.
psychiatric, we feel like that.
We
They
have
might have a light sensitivity.
now we got so much information. That's why we are
The gray matter is squeezed.
Organizing those information, because a lot of
Yes.
work, and how many pages I have written.
Yeah. Yes. Yeah. It's good.
I'm
You'll need
I'm
them.
enjoying. I mean, basically, I'm
Yes.
not tired, and thank you so much.
Yes. Yes. The more information you write down, and after the session, I'm gonna tell everyone what you're gonna do. Yes. As I see that we are almost 85. We might consider just I'm gonna see next session how many is gonna come from the rest, because the group has 180. Yes. So I'm gonna see how many is gonna come, how many is wishing really to study. If it's just only the 80, I'm just gonna send for you guys the link here. I'm gonna just create a new group, and the old one which you have now, I'm just gonna close it. Yes, because there is 180. Yes, I have respect for everyone, but if only 80 just joining us, we need to concentrate. I need to focus on them. I need to follow up with them more. Yes, it's not gonna be easy for me to follow up with 180, but if it's just 80 or 100, I can do it. The previous group was double this number. Yes, so the previous group was almost 170, and after the first month, it just decreased. We lost almost, I think, around 40 doctors, and we just got few people on the middle of the cycle as well too. We did increase again. By the end of it, also 40, 50 doctors, they just got disappeared. It's not like they disappeared, but some of them, okay, they are not serious yet. They are not ready to finish the exam yet. So that's why I keep just moving only people who's wishing to finish the exam to have a smaller group. And that's what we're gonna do here. People who's studying, people who's working hard, I'm gonna just create a new group, which is gonna be only for those. Yes, I think it's gonna be fair for everyone, and it's gonna be better just to follow up easier. It's gonna be just better for everyone here to have access to the materials all the time. A smaller group, it's mean less maybe questions, less interruptions, better for everyone. Let's move on. The patient is coming to you. Schizophrenia. So, okay, next question. Dr. Andrew, come try your luck again.
Yeah, they are half asleep, so I'm ready.
Yes, the more you prepare for this exam, you're gonna get more sleepy, yes? But I would say something for everyone. Do not think that if you quit your job, if you stay at home, if you maybe leave your duties or tasks, or if you sleep maybe 9 or 10 hours, you're gonna feel good. You're gonna wake up, you're gonna feel headache, you're gonna have the same bad feeling. If you leave your job, you're gonna find your wife, she's asking you to do something at home. If your husband's gonna tell you do this or do that, you're gonna find the kids, you're gonna find whatever the family is doing around you, you're gonna be always busy. So whatever the situation you are, guys, on now, please work. The last cycle, I did just bring people who did pass from the last batch, and inshallah soon I'm gonna just bring for you people who did pass, inshallah, from the previous group too, to speak with you, to tell you their story, how they suffered, how they worked hard, what happened to them. I had one doctor, she had a newborn. She was holding the newborn and walking while listening to the session, finishing the task while the newborn is sleeping on her feet, yes, or legs, sorry, on the legs, and she was just doing her hard work. She was crying. She was feeling so bad. She felt so disappointed, but she did work hard till passed the exam. Please do the same. The question for you, Dr. Andrew. You have the patient is coming to you. You found your criteria. You became so happy. After you became so happy, you thought, okay, they give me the criteria, they're going to ask me about investigation. Unfortunately, they told you that they have done the investigation. After you reach to this point, you thought, okay, now they're gonna ask me about the treatment. You found out it's emergency case, they gave the IM, haloperidol and lorazepam. After they gave the treatment, you thought, okay, they're gonna ask me about the good prognostic factor. They gave it to you. What do you think they're gonna ask you about this? Patient
Recurrence,
came to you, did investigation, you did treat, you did find good prognostic factor, everything is done. What do you think they're gonna ask you?
follow up,
Okay. How are you gonna follow up?
educate about red flags.
Okay, so one thing they can just ask you about it is, they can ask you about how long you're gonna keep these guys on the medications. So you are giving them maybe haloperidol or aripiprazole, which they prefer nowadays everywhere because it has less side effects. So what you gonna do?
Well, it depends on the history. If there's a recurrent history versus a simple, like uncomplicated, I would say, schizophrenia, this dedicate the duration. If a patient is a high risk, they will need more time of maintenance.
What is the more time for you? Dr. Andrew, once you're stuck in your exam, what is something you're gonna wish to have in your hands?
Reference.
The book, TN.
Reference.
Yes. Once you're stuck, you're gonna find this lovely line written in your TN. You're gonna find the answer between the lines. Maintenance of the treatment, 2 years, if it's the first episode. 5 years after multiple episodes. They love to ask about this point. Now they asked you about all this. You come down, you find something new. What else they can ask you about in schizophrenia? You did make the diagnosis, investigation, good prognostic factors. They asked you about it. The treatment, resistant. You give the clozapine. Did they ask you about the maintenance? What else?
Psychosocial.
History of head injury or brain problem.
What else?
Prognosis.
Let me read it.
Family.
Doctor is reading TN.
Cycles.
Good job, yes. The more you read in TN, how many times I did read this chapter or I did go through the book? Every time I go through it or I prepare for the session, I find something new. So do not say for yourself that, oh, I need to digest each single word. That's why I told you during the introduction session, I told you that you don't need to read every single word from the beginning till the end. It's wrong. People, let's make a group for TN reading session, guys. And they open the book. Oh, management, schizophrenia, pathological, somatic, acute treatment. By the end of the day, you don't have information. You have only headache. Yes? So what do you think they're going to ask you? Come on, guys. Come on, guys.
You treated the patient.
Side effects.
You did treat. You did make your investigation, Dr. Andrew. You did make a good prognostic. They ask you about it. They ask you about the resistance. They ask you about everything. You come down, you don't find any of this. What do you think they're going to ask you?
Adjunctive treatment.
No, treatment is done. They are not asking. They treated already the patient.
Psychological support.
Psychotherapy.
Side effects.
I know, why are you going to go for psychotherapy?
Side effects of
Side
medication.
effect.
They love something more to ask about it. QE1 MCC objectives. They love it.
Liver function.
Unfortunately, something else.
Social skill trainings.
Relapse.
The thing here is, I hear sometimes people, they are saying something around the correct answer, but they don't speak. Yes, they just have a shot. Pew, pew. You don't see them again. They
Let's
shot
see.
it, and yes.
Is it social determinants of health?
Tell me, doctor, what you mean with social?
Social determinants of health, like there were 12 or 15s, like their education level and all those things, like
Maybe
Okay,
those
rehabilitation.
things,
they
eating
gonna
habits.
come down to ask you about
Housing, group home or boarding home.
how
Support group.
will you support this
Support group.
patient?
Yeah, social support or social
Supportive community group.
What is your advice
Stop.
for this patient? People, they go to the exam, they come back to tell you, I did go for my exam. Patient is treated, investigation is done, everything is done, and they are coming down to ask me about advice. I didn't know what to do. Now it's your chance to study to know what you're going to do in your exam. Please study only from your book. Once you are so good with your book is full with information. Yes? So how long we have been speaking now? We are just on page number 8. But just the few pages, it's taking a long time. Once we pass the mood disorders, we're going to be flying. Next. How are you going to support?
support group.
What is the support group? What is
We have
AST
to get them
or
the
ACT? Sorry.
living skills, help with the living skills, help with job
Yes, it's
placement.
groups which is telling you find other people who's controlled maybe and so on. Yes, you meet them maybe. Yes, the community just it's helping these guys. So it's like supportive community which they have for the smokers, for people who's drug users. Yes, to help them to just engaged or be engaged in the society again. Because if you have a schizophrenia patient and he's not taking medication, do you think he's functioning or he's not functioning?
Is not
It's
functioning.
not functioning. So he might, or he most probably he lost his job. Yes, because of the psychotic
Yes.
features or whatever it is. So you'll get them just shortly or slowly back to the society.
Right.
So over the time, you need to remember that 1/3 is improving, 1/3 is remaining the same, 1/3 they are having or the symptoms is getting worse.
Right.
So usually when you are treating and you're giving your antipsychotic, you are treating the positive and the negative symptoms. So they are writing for you here that the positive symptoms, typically it's getting less or it's improving with the treatment. Negative, sometimes it takes longer time or it's not much improving, yes, but it takes some time longer than the positive. No questions here? Treatment important. We didn't digest treatment nicely, but I did go over the important points. Yes. Housing, they have a social skill training. Yes. Employment programs, which is specific for them, what you're going to do, how you're going to do it. Prognostic factors, we spoke about it, how long you're going to keep the treatment. If the treatment is resistant, what you're going to do. If it's emergency, what you're going to do. Yes. Risperidone, they wrote for you aripiprazole. Aripiprazole, of course, it's less side effect and the best between all the medications, but they don't give it too much. Why? Because they know that you're going to pick it up, you're going to find the right answer, you're going to move. That's why they don't give it too much. Next question. Next question. Who's going to take the next?
I can take it.
Okay, doctor.
Dr. Tuba Khan.
Oh, doctor. Hello, Dr. Tuba. So let's try your luck for today.
Yeah. 28-year-old woman is brought to the physician after she was found to be acting inappropriately at
So
work.
I need you to practice this next, guys. So I did develop a method which is called SR method.
Okay.
Usually people, they are saying for you, oh, I do scan the question. Oh, I do read the question. It's wrong. It's a combination. It's SR method. It's a scan reading. I did develop it. I'm going to give it to you. It has few steps how you need to approach your question.
Okay.
Yes? How you need to do it. Usually, they're going to give you a question which is down here. You need to read this part. Read this question.
Okay.
After you read this question, you have the key in your hand. They're asking you about treatment. They're asking you about advice. They're asking you about investigation. They are asking you about the next best step. They ask you about initial best step. That's the first thing you read it. You read it by the meaning you read it. Next. You go down, you find A, B, C, D. Here you're gonna scan. What is the meaning of scan? Scan means that you are not reading, but you are moving your eyes quickly. Yes? You are not exactly reading the words, but you are moving your eyes quickly through the options. That's how you scan. 1 second, you are moving your eye. Okay, you saw it's reading. They are asking you here about diagnosis, and they are giving schizophrenia, delusion, schizophreniform, and schizoaffective, and they are giving you bipolar. You did find out what you are looking for. Now you're gonna go ahead and start from the beginning. I'm not gonna give you the full method now. I need you to, this is part 1.
So basically, you're saying to read the question first, like the last line. What are they
Yes,
asking? Yeah.
read it.
Got it.
Yes, read it nicely. Find out what they are asking. Are they asking you about a management or a diagnosis? Are they asking about advice or next step? They asking you about a legal advice, or they asking you just about a duty?
Okay.
Yes. Then you scan here. Yes. Then you're gonna go to the beginning of the question. You are looking now for what you are just, you have found out what you need to find from the question. And now you start from the beginning.
Okay.
This method, once you take it fully, I need you to practice this part for now. Once you get the full SR method, guys, it's going to increase your speed. You're going to find yourself that you understand and you remember the question nicely. You will find yourself very effective approaching the questions. It's a skill. It's not like people, they come, they keep doing questions in UWord or ACE or whatever it is, and they go to the exam, they are shocked. They don't have the skill. Yes, they have the tutor mode, they have maybe time mode. That's why we are solving this, and we're going to work on this. We're going to train on the style of the questions. We're going to train on the method which you're going to use for the questions. We're going to have mocks which is going to test you in each subject to see how ready you are to challenge this exam. Please read it, Dr. Tuba.
But there is no question.
Yes, there is no question here, but just read this one. So they're asking you here about the diagnosis.
Yes. Okay. So what is your diagnosis? And a 28-year-old woman is brought to the physician after she was found to be acting inappropriately at work. According to her co-workers, she began acting strangely 3 months ago. At that time, she began wearing a hard hat to work, and when asked why, replied, "I will not let you read my mind." She also believes that others are talking about her and routinely asks them to stop. On several occasions, she had to be escorted out of the room because she started to argue with others whom she believed were controlling her mind. What is your diagnosis? And then options.
What do you think? Is it easy question? Is it hard one? What do you think?
I would say it's somewhere in the medium because I am I mean, they have given the time 3 months ago, like 3 months.
What is the 3 or 4 things I told you once you find a question and it's asking you about diagnosis and you find schizophrenia there you need to look for? Tell me, please. Repeat it to me.
The positives and negatives.
So
And
DSM-5, you can apply it here, but I told you once you see a question, what you need to look for. Number one,
the question
mm,
and then the
something else.
option.
I did say about it when we did study schizophrenia just a few moments ago. Who's
Duration.
gonna remind us, guys?
Can I chip in?
Duration
Number of
Duration.
psychotic
First,
symptoms.
yes, you need to count, Dr. Tuba, how many psychotic symptoms.
Psychosis symptoms.
Yes. So over
Then,
here they only gave us one, and then the time period is 3 months.
yes, then you need to look for the duration.
Yes.
Then you
3
look for
months.
the mood symptoms, if it's there or no. 3 things.
Hmm.
Count for me,
So
please, how many symptoms.
so I have I can only see one symptom, and duration is 3 months, and there is no other mood like just psychosis of
Mm,
that's it. Hallucinations.
There is an argument.
Is
mm.
delusion.
Argue. I mean that's yeah, but
What do you think, Dr. Sadia?
I mean that
I
is
think
impairing
it's
the functionality.
yeah, I think there's 2 symptoms.
Mm.
2 symptoms. Okay.
Yeah.
Hallucinations and delusions.
So she was found acting inappropriately at work. According to her co-workers, she began acting strangely 3 months ago. Your duration.
Brief.
She is saying, I won't let you read my mind. What does this point telling you guys?
Delusion of rep.
Delusion.
I won't let you read my mind.
Bizarre delusion.
Bizarre. Is it bizarre or non-bizarre? That's what you
Bizarre.
need. Once you are thinking about schizophrenia or any of her sisters, you need to ask yourself, do you see in this patient bizarre or non-bizarre? Is it auditory hallucination or no?
No.
She believes that others controlling her mind. So you call this bizarre
Delusion.
Very nice. Dr. Tuba, in order to make the diagnosis for schizophrenia, how many symptoms do you need to find?
2 of any of the positives and rest and other one from the negative for at least 6 months. That's
You need to find
schizophrenia.
2 from the positive? Dr. Tuba, what did we say?
Oh my God.
One.
I think that's what he said.
At
It's
least
almost
One for me.
1, Dr. Tuba.
One
Dr.
positive
Tuba,
and
let me
Yes.
say for you, W.
Yes, wake up.
Wake up. You need to find one of the 3 symptoms. What is the 3 symptoms, Dr. Tuba?
Hallucinations, delusions, and disorganized behavior.
Thank you so much. Did you find one of them now?
Yes.
What you are missing to say it's a schizophrenia or any of the sisters?
Sorry?
What you are missing to say it's a schizophrenia or any of her sisters?
It's the sisters, not schizophrenia, because duration
So
is also there.
duration, but symptoms you didn't get it complete because you need 2 or more symptoms, at least one of the first 3.
Yes. So
Repeat
that
it
was
again,
only
please.
delusion here, right?
Please repeat the criteria again.
So at least 1 out of 2 symptoms, hallucinations and delusions.
2 symptoms or 3, Dr. Tuba?
Oh my God. Okay.
You need to write it down, otherwise you will never
Yes.
remember it.
Yes.
One of the first 3, delusion, hallucination, and disorganized speech.
1 of
2 or more symptoms present. More than 6 months, you call it?
Schizophrenia.
Between 1 month and 6 months, you call it?
Schizophrenic form.
Less than 1 month, you call it?
Psychotic
Brief psychotic disorder.
If you find a mood disorder or a mood symptoms, what you gonna call it?
Schizoaffective.
Schizoaffective.
She's effective.
Yes. So this one, you find this here, yes. You find a paranoia here, things that others talking about her. Yes, she's worrying. So change in the behavior. She is acting inappropriately at work. Yes. So she has impairment. Yes. Needs to be. They needed to do what for her to make sure that everything is going to be
They
great?
needed to escort her out.
Escort
Yes.
her. To make sure. This is telling you dysfunction with other words. They are not
Yes.
going to just come to you to tell you, oh, she's dysfunction. Oh, they are not going to come to you and say, oh, she is having delusions. She is having hallucinations. They're going to explain it for you and you just understand. That's why we did spend some time in the beginning to study. What is the difference between delusion? What is the difference between hallucination, illusion?
Yes.
Did you get it, guys?
Yes. Yes.
Yeah. So, very nice. So, the diagnosis here, Dr. Tuba, what it is?
Schizophrenia form.
Schizophrenia form. Thank you so much.
You're welcome.
So, if you go back to your book, you're going to find out more than 1 month and less than 6. Treatment, similar to schizophrenia. We're going to speak about the treatment later. The next one. Who is going to take... Dr. Tuba, next time I'm going to ask you to repeat all schizophrenia and the sisters.
Yes.
Please have it in your notes. Try to take notes now because I'm going to ask you to repeat everything.
Yes, doctor.
So please, next question. Someone new, come try your luck. Someone wishing to pass this exam, come to take the questions.
Let me try.
Okay. Okay, just quickly, guys. If you wish to take a 5 minutes break, guys, just write yes on the chat.
Up to you, sir.
Please, if you wish, please write yes on the chat, guys. Dr. Curran, do not say anything, please. Because I'm listening to you laughing. Guys, if you wish to take just a quick break, it's just 5 minutes. Write yes on the chat. Let me see. Please, guys, only 5 people they are writing. Where's everyone else? Write on the chat, guys.
1 minute.
Yeah, 5 minutes, guys. So 5 to 10 minutes. Please write on the chat.
Okay, 5 minutes.
Please, guys, write on the chat. Please, whoever wish to take break, guys. Break.
Break.
Break,
5.
guys. Break,
5
guys.
minutes.
Yeah, I see so many is writing yes, 5 minutes. So, unfortunately, because everyone is writing yes, we gonna do what?
Continue.
We gonna continue. There is
The
no
trap.
mercy.
No mercy.
It was a trap. To find out who is wishing to
Wake up.
wake up. Please. Please, guys.
Where are my pages?
Yes. Wake up. No break. You can take a break after you finish your exam. Before your exam, you cannot go for a break. There is no mercy for this exam.
Good.
So let's study. Let's study, guys. I love to see people they are writing yes. Let's see who wrote yes. Okay, Dr. Mariam, please, since you wrote yes, you want to take a break, come take a question. Dr. Mariam, please. We were just asking not to go for a break. We were asking who is going to take the question, and you wrote yes. Dr. Mariam, please.
She's broken.
Dr. Mariam.
No.
Are you here?
She just wrote no.
I think she went for a break.
Okay, Dr. Ruba. Dr. Ruba. Dr. Ruba, are you here?
Yes, doctor, I'm here.
Yes. Since you wanted to go for a break, come take the next question. If you answer it right, we don't go for a break. If you answer it wrong, we also don't go for a break. So please go ahead and tell me. They are asking you what's the diagnosis. Please.
Okay. So I will read it loudly.
Yes.
Okay, 35-year-old woman who recently migrated from China is brought to the emergency department by neighbors after she was found wandering in the streets yelling out someone's name. She appears disheveled and grossly disorganized. You learn that she arrived in the US several days ago. And upon her arrival, witnessed the death of her 3-year-old son. While in the waiting room, she appears to be responding to internal stimuli. Her psychotic symptoms resolve fully within 1 month.
Very nice.
Okay.
Please, once you find a question for schizophrenia, what's the 3 things you're going to look for?
We have to look for the psychotic symptoms.
You are looking for psychotic symptoms to apply your DSM-5, the criteria. The second thing you need to look for?
The duration.
Duration. And the last thing you need to look for?
Impairment of functioning.
If there is?
Disorganized speech.
No.
To rule out.
No.
Mood.
Mood. Please, guys, I keep
Yeah.
telling everyone, have it in your notes. If you don't write it down in your notes, it's not going to help you. Do not depend on your memory here. You need to have it in your notes. Then you're going to have the information solid in your head. Otherwise, you're going to forget it. You're going to just never study it. You'll never do anything. Do not rely. Recording by yourself, it's not allowed. Yes. So do not rely that you're going to just do it. I'm recording the session. I'm going to start to upload it on the site soon. But if you are doing this without permission, first of all, I'm telling you, 99.9% you will never ever listen to it. Why? It's a 4-hour session. If you didn't attend it live, you will never have the 4 hours to study it. To study a session which is 4 hours by yourself, it's going to take you at least 2-3 days. You have no 2-3 days. You're going to have more tasks. You're going to have exams coming soon. You're going to have more checklists. You're going to have more notes to get it done. You will have never time to go and review it. So your chance to study while everyone else studying. Please start to take notes. If you didn't do from the beginning of the session, it's never late. Please. Okay. Dr. Ruba, please repeat for me the 3 things again.
The psychiatric symptoms, the duration, and if there are mood symptoms.
Please apply this in this vignette.
Okay. The patient has disorganized behavior. And
is disorganized behavior one of the first 3 in the DSM-5 or no?
No.
Yes.
Repeat for me the first 3, Dr. Ruba.
Delusions, hallucinations, disorganized speech. Yeah.
So what do you think?
She's having disorganized behavior. She's wandering in the streets and yelling. And also, and disheveled, which are negative symptoms. And grossly disorganized. This is disorganized behavior also, or negative symptoms, I mean.
What do you think?
And Yeah, and also at examination, she's responding to stimuli. So since she has
So
hallucinations.
what they wrote for you here, Dr. Ruba?
Grossly disorganized.
Yes, what does it mean for you?
That means in her behavior and appearance.
Is it only in behavior?
They didn't say
They didn't
like
explain.
clearly in her speech.
Okay. So, where it is? Okay, so appears you learned that she writes. Okay, severity upon her arrival. Yes, she witnessed the death of her 3-year-old son.
It's a trauma.
While in the waiting room, she appears to be responding to internal stimuli. What this line means for you?
That means she has hallucinations.
Thank you so much. Thank
So
you
we
so
have
much.
two symptoms. One of them is one of the positive symptoms, which is the hallucinations.
Not only this.
Yeah.
She was found wandering in the streets, yelling out someone's name. Is it something normal or abnormal?
No, this is disorganized behavior or weird behavior.
Okay, so this and grossly just disorganized, it's abnormal behavior. The psychotic signs, which is hallucination, she is responding to internal stimuli. Yes. And you need to think that there is two points here they are saying for you. What is, first of all, the diagnosis? Super easy.
Yeah, it's a brief psychotic disorder.
Because it's within 1 month.
Yeah, more than one day.
What do you think the reason this lady is presenting to you with a brief psychotic disorder, doctor?
When there is a very stressful event happening.
What is the very stressful event here?
The death of her 3-year-old
Thank you
son.
so much. That's not only the one. What is the
And
other one, doctor?
immigration also to a new
And
country.
she recently immigrated.
Yeah.
Several days. Pre-psychotic. Thank you so much.
Thank you.
Do you see pre-psychotic before you go, Dr. Ruba? Does it happen more in ladies?
Yeah.
Or does it happen more in men?
It's more in ladies, especially postpartum. This is one
With
of
postpartum. So if
after
you
delivery.
yes, if you go to your book, you're gonna come down here and find out that they are writing for you postpartum.
Yeah, the new term, I think, psychotic disorder with peripartum onset.
So next question is very challenging. Thank you so much, doctor. Thank you,
Thank
Dr.
you,
Ruba.
doctor.
So, I
Now-
have a questions, please.
1 second, doctor. Yes, Dr. Ala.
So just I didn't
Dr. Ala,
yeah.
you know my deal. Deal or no deal?
Yeah, deal.
Okay, please. So the next question for you. So my regular deal, Dr. Ala, is Doctor, please, everyone else close the mic except Dr. Ala. So the regular deal is, Dr. Ala, that's you have a question, I have a question. You answer mine, I answer yours. The new deal is I have a question and you have a question. If you answer mine correct, I answer yours correct. If you answer mine wrong, I answer yours wrong. How about it? So do your best. Please answer the question.
Okay, I will try.
Yeah, do your best.
A 25-year-old woman is brought to the emergency department after being found walking nude in the shopping mall. When asked why, she replies, "I'm making it easy for others to have sex with me. Since I know they all want me." She said that she hears a voice telling her she is irresistible and everyone wants her. When she speaks, she cannot focus on one topic at a time, and her speech is rapid. Her mood is euphoric, and her affect labile. We recounts an episode last year where, although she did not have an elevated mood, she heard voices she could not describe and believed others were following her. These symptoms lasted for plus 6 months and caused her to lose her job.
They're asking what is the diagnosis. What do you suspect here?
Schizoaffective disorder, because there is mood.
Once you see a schizophrenia or any of her sisters' question, what is the 3 things you're going to look for, Dr. Ala?
You're going to look for the symptoms, like one of 3.
You're going to count how many symptoms to search for the DSM-5 criteria, then
the time, and then the mood symptoms.
Duration, and you're going to go look for the mood symptoms. Please apply this on the question.
Okay, so she's naked and she's saying that I'm making it easy for others.
Okay, so everyone wants to have sex with her. Okay, what else?
And then she has like auditory hallucination.
So they have a word which they wrote it for you here. She's telling you she is irresistible. What this is telling you?
Like mania. She has mania, something manic.
This is telling you she is grandiose.
Yeah.
Or maybe you could apply it under erotomanic delusion. Next. What do you think? What is other finding in this vignette? She heard voices she could not describe. Yes?
Yeah.
What do you think?
Is it hallucination? Like she hearing voices, but...
So which hallucination it is?
Auditory hallucination.
So...
And her speech is so rapid. So this is like
speech is rapid.
Yeah.
Okay, rapid speech. She cannot stay in one topic. What does it mean for you?
Flight of ideas, which
Could
is
be, yes, that's we spoke about it, yes. So
euphoria.
Yes. So what do you think? So you have mood symptoms plus you have hallucination.
Yes.
Last year, she got psychotic symptoms for 6 months. Hearing voices, paranoid, believing that people, they are following her, but no elevated mood at the time. This is your answer for the question. When you go to your book, again, schizoaffective, you're going to go for the criteria A plus major mood episodes. It could be an MDE, it could be manic. 2 weeks. Yes? So 2 weeks of a psychotic symptoms without a mood symptoms. Schizoaffective, you need to find your criteria, schizophrenia criteria, plus you need to find mood. It's either MDE or it's going to be manic. Plus, you need to find a period of more than
2 weeks.
2 weeks without
psychotic symptoms.
Without psychotic or without mood symptoms?
Without
No,
mood.
without
Absence
mood
mood.
symptoms, sorry.
Without mood.
Yeah.
Lady, she is coming to you. She is psychotic and she is manic. And we're going to speak about mania, flight of ideas, grandiosity, all of these. She's telling you that 2 months ago, she had an episode of only psychosis without mania for 2 weeks. You're speaking about schizoaffective. That's why I told you. Once you find the schizophrenia or any of her sisters, you look for symptoms, you look for duration, you look for mood. Very important. ABC. If you miss any one of them, there is a very high chance that you're going to miss the question to solve it correct. What was your question, Dr. Ala?
I couldn't understand the internal stimuli means, like, that's
internal stimuli that she
hallucination?
is sitting, it's like you are not speaking with her. She has something from inside just making her to jump in or to speak with, or she's just getting irritated. Something is bothering her, yes? So you are not, it's not external. It's not you speaking to her, but she has something coming from her by herself. So if you have someone is sitting, normal patient or normal person, they are not going to do anything, yes? So you're going to have someone speaking to them, they're going to answer. These guys, they are sitting in their place and they are, oh, he's the one who's told me.
Okay.
That's it.
Okay, this account as a hallucination?
You can count it as she is hallucinating. So she can be staring somewhere. Yes, the 1,000-yard stare, which we spoke about. Usually they love to give this 1,000-yard stare for people who's coming from war. Or they can tell you the person is staring on the corner, or you are asking him, he is not answering you except after some time, or he is looking around while speaking to you. Yes, so you're suspecting he's hallucinating.
Okay, yeah. Thank you, Dr. Abdullah.
Thank you so much. Next one is gonna go for Dr. Riaz. Are you here?
Yeah.
Please.
38-year-old man comes to the physician because of marital concerns. He has been married for 10 years, and during the most of these years, he has believed his wife has been lying to poison him to get his money. He frequently complains of stomach pains, which he believes is due to the poison in the food. His thoughts are logical and coherent. He denies any hallucination. His wife, an independently wealthy woman, does not understand her husband's logic because she has more money than he does.
What are you gonna do?
So many things here.
Yes, tell me what you need to do in this situation.
One second.
I gave you the answer early, Dr. Riaz. Please think about it, analyze the question, and please tell me.
Yeah, one second. Delusion.
Delusion what?
And no hallucination. And yeah, I mean delusion, because he's thinking his wife is poisoning and that he has more money than his wife. Actually, his wife has more money than him. So it's delusion. and its duration is more than 10 years. And
what do you think?
It is no mood disorder. So it is what I will say, schizophrenia. If I say schizophrenia, so
if
I
you say schizophrenia, Dr. Riaz, you need to tell me the DSM-5 which you did apply it here.
Yes, that is what I'm saying, that if I say schizophrenia, I have to see at least
if you don't find the criteria, you say it's not schizophrenia or any of the sisters.
Yes.
So you did exclude the answer. That's why you start with counting the symptoms. If you find the DSM-5, you say, okay, it's one of the sisters. Then you go for the duration to determine which one it is. Then you go for the mood symptoms to make sure it's the schizoaffective or no.
Yes, I did all three.
From the beginning, if you don't find the symptoms, it's A, B, C for you. It's not what you're looking for.
Okay. Got it.
It's one of the biggest or common mistakes which people they are doing when they are studying for QE1. Once they see or find a similar vignette or scenario, they say, okay, maybe you are thinking about TSS, or you are thinking maybe it's asthma, or maybe COPD. It's similar to it, but you cannot apply your criteria on it. Then you exclude it from the answers. It's not. Because what they aim to do is, because it's similar to asthma, it's similar to schizophrenia, you go down, you choose it, and you run. Thinking from you that you did correct, it's wrong. Once you cannot apply your criteria, it's not your answer. Look for something else. What is the answer here, Dr. Riaz? I give it early. What do you think?
Psychotic disorder? Generally, I speaking generally. But
okay, let me solve the question with you, Dr. Riyad. Physician because of which problem? Why he came?
Because his disbelief, I mean delusion.
Because of?
Delusion. He has disbelief that his wife is poisoning him for 10 years.
Okay. So he has been married for 10 years.
Right.
What this information telling you?
I mean, they are married for 10 years.
Yeah, what this information is telling you, Dr. Riaz? Everyone, what this information is telling you guys? Come on, squeeze your head.
So out of 10 years, most of these years, he believed that she's giving her poisoning. I mean, she's poisoning him most of the year. I mean, most of the years mean at least. Sorry?
Okay. Do everyone agree, guys? Do you agree with Dr. Riaz?
In 800 meters, keep left to continue on Queen Elizabeth Way. All signs for quantum Queen Elizabeth Way.
Are you driving? Who's driving, guys?
My son driving, and I told you I am traveling.
Oh, Dr. Riaz. I was wondering. No, you are so dedicated. Okay, Dr. Riaz, that's okay. That's okay. Just drive safe. So, guys, please tell me, married for 10 years. Dr. Andrew, please tell me, what do you think? What this information is telling you. Dr. Sadia. Dr. Ruba. Dr. Tuba.
6 months.
That means his relationship with his wife is stable, his marriage is stable and not affecting these thoughts in his mind.
Not really.
But he has a stomach pain because he's going to the doctor.
This information is telling you
it is functioning, like he's functioning well, right?
This information is telling you the more you stay married, the more psychotic problems you get.
Got it.
So you see, the guy's only 10 years and he is coming to you with a stomach pain. He is having a big problems.
Yeah.
Please do not do anything bad. Keep married, be married, guys. Please. Please. So 10 years. During the most of these years, he has believed his wife has been doing what, Dr. Riaz?
Poisoning him because
Poisoning him. Tell me what it is.
This is a disbelief. I mean,
Dr. Riaz, since you saw this word, you were supposed to tell me one word.
I mean,
Delusion.
He has delusion. Delusion.
What
He has
type of delusion, Dr. Riaz?
This is a bizarre delusion.
Is this bizarre, Dr. Riyad?
Yes.
Is this bizarre, Dr. Riyad?
Because he has no reason to say
Dr.
that.
Riyad, bizarre, which you need to have in your notes, you will never forget about it. It's mean that there is an alien, there is zombies, there is something not real.
Okay, so if it is
non-bizarre, it's mean that it could be a poison, it could be a gang trying to kidnap them. Can this happen in real life? Yes,
okay,
it
so
can.
non-bizarre because
so that's non-bizarre.
Yeah,
Once you find non-bizarre, what you're gonna think about? Is it schizophrenia or something else?
It is something else for sure because it's
what is the something else we spoke about?
Delusion.
Delusional disorder.
Disorder. Yes, that's what I want to say initially.
Yes,
because I mean, his complaint, everything is not fitting for the
he's
schizophrenia.
complaining. Yes,
he has only delusion because 10 years of marriage, so many things can happen, but he's fixing on stomach pain, simple stomach pain, and thinking voice is pausing. He should have died in the 10 years. If
it's
she's
not good. Yeah, it could be not a simple stomach
if
pain.
she's really
but he's-
poisoning him, he should have gone.
Yeah. So he believes that it's due the poison in the food. Yes.
Yeah.
So he denies any hallucination. His wife is independently wealthy lady.
Yeah.
Yes, does not understand why her husband logic to do this.
Yeah. So she is more richer than him, and then he has total
Yes.
delusional disorder.
Did you find out how delusional
Yes.
disorder looks like?
Yeah. Got it. Thank you.
Yeah.
You made it easy.
Yeah, I'm so happy. I need you guys. Okay, I think that's the end for today. Let me stop the recording.
Sorry, I was